Hello, hello. A very good morning to everyone. I welcome you all to the day 2 of Issfn CME 2023 at Aiims Jodhpur. Today's sessions deal with epilepsy. For the first session, I invite the chairpersons, Dr. Amita Bhargava, Consultant Senior Neurologist, Jodhpur, Dr. Manish Parak, Senior Pediatric Neurologist, Jodhpur, and Dr. Pushpinder Khera, Professor and Head, Diagnostic and Interventional Radio Diagnosis, Aiims Jodhpur.
Thank you. Very good morning to all of you. So I invite the first speaker, Dr. Sarvesh Tiwari. He is working as associate professor. He's my colleague here in the Department of Radiology at Aiims Jodhpur, and he'll be speaking on MRI imaging protocols in epilepsy.
Good morning, everyone. So, in the next 10 minutes, I will elaborate the protocol that we follow here and what is recommended and what is ideal. So, whenever we talk about pre-surgical evaluation of epilepsy, our main goal is to identify the epileptic lesion, what is causing this seizure, and then to comment on the resectability, the extent of resection, relation with the eloquent areas, and then the follow-ups of the patient. Now, we do have options like most of scanners now are 1.5T and 3T is being replaced at most of the at least tertiary care centers and educational institutions. Now, to understand that if you have an option of choosing between these two, always choose the higher magnetic strength scanners, because there are multiple studies which says around 2 to 2.5 times more chances of picking an epileptic lesion on a 3 Tesla scanner, and if 7 Tesla is available, I don't think we have any 7 Tesla in any of the academic institutes, but if you have that option, a 7 Tesla picks up even more lesions than compared to a 3 Tesla scanner. Let me see the pointers. Yep. So 3 Tesla has increased signal to noise ratio, and certain advanced imaging sequences are there which can be run on a higher magnetic strength scanner. Now, when we talk about protocol, ILEA came up with this harness protocol, and they talk about acquiring at least 2 3D scans, one a T1 weighted image, a T1 gradient sequence, and the other a flare gradient sequence. These are isotopic voxels which can be reconstructed in all the 3 planes. So these two are bare minimum. We need a 3D T1 gradient echo sequence and a 3D flare sequence, and they recommend a bare minimum of a oblique coronal T2 weighted image which is oriented along the hippocampus. And they have kept gadolinium enhanced, that is a contrast enhanced MR in optional sequence, and an SWI in optional. But now in our country, where neurocysticercosis or a post-tubercular phenomena is not very uncommon, I think SWI should be a mandatory sequence for imaging in epilepsy, at least in the poor income countries and middle income countries. All right. So this is the protocol that we follow. We acquire a 3D T1 weighted gradient echo sequence which can be reformatted in all the 3 planes. A 3D flare, these are the main sequences, followed by a high resolution oblique coronal T2 weighted image which is usually 2 millimeter in thickness, and SWI is mandatory according to me. And now we are venturing into this 3D T2 MP2 range sequence and 3D edge, which I am finding very useful in the neocortical epilepsies. Contrast is routinely not needed and may be needed in a patient with first seizure where a gangliomatous lesion is being suspected, or when there is a possibility of a long-term epilepsy associated tumor or vascular malformation. So these are the gamuts of different kind of images that we get. A 3 millimeter T2 weighted image. This is an oblique coronal T1 IR, a 3D flare, a 3D T1 MP range. This is a granuloma identified on a SWI image, and then an MP2 range sequence. Now, you need to optimize each of your sequences as per your liking. If you see, these are 3 images, all of them are T2 weighted image. This is a fat suppressed sequence, a normal T2 non-fat SAT sequence, and this is a T2 stir. Now, when you're talking about epilepsy patients, we need the great gray-white matter differentiation. And in a stir image, when you use stir, you see it gives the best gray-white matter resolution. So small tweaking doesn't cost a time, and it's available with all the scanners. So a T2 stir in axial actually works better for patients with epilepsy. Now, we have to understand, we are too much reliant on using flare for the looks of hippocampus, which should not be so. It's the T2 which is better suited for evaluation of hippocampus and not flare. These allocortices, which are 4 layers, they can inherently appear bright on flare, and hence it should be seen in conjunction with T2 when we've already identified a pathology on T2 weighted image and you want to confirm it on a flare. And there's one more thing that we see. Most scanners, when they do epilepsy scan, they kind of limit the oblique coronal sequences to the head, starting from the head to the tail of the hippocampus. The story doesn't always fit in the hippocampus or the middle temporal area. You have the entire brain to look at. So don't image only the hippocampus. It should be the entire brain which should be imaged and not the hippocampal area. Now, why this oblique coronal T2? Now, even ILI recommends this as a mandatory sequence. Now, it's a voxel size of 0.4 into 0.4 into 2 millimeters. They're very small without any interslice gaps. And if you acquire, you get this beautiful kind of images where you can differentiate the different subsectoral zones of the hippocampus. This is the dentate gyrus with CA4 and then CA321. And to understand that when you're looking at the hippocampus, different subfield areas, it should be like this, like a tapered point opening up very smoothly outwards. This is normal configuration. You should try to see this sequence in everything, because you will find selective involvement of like a CA1, which is very common, or a CA4 zone, and there is selective hyperintensity in that area, which might not be seen in a lowered subfield scanners. So this is an example where this is the scanner. You can see that yes, there is a right-sided hippocampal sclerosis, but if you see carefully, you can actually see the different subfield appearing hyperintense. The CA1 appearing completely hyperintense here, and this normal tapering that we discussed in the previous slide is absent in this case. So try to look into the hippocampus and see the different subfields. Now, why to acquire the entire temporal lobe, or the entire brain, rather than the hippocampus? So many patients we are seeing temporal pole blurring associated with hippocampal sclerosis. Now, the etiologies have been discussed differently. They say because of prolonged epilepsy, there might be dysmyelination of the anterior temporal white matter and gliosis, or it can be secondary to type 1 FCD is associated or sitting together with a mesial temporal sclerosis. So, like this example, it is quite evident that we have a left hippocampal sclerosis. But if you look carefully at the anterior temporal pole, you can appreciate the paucity of white matter at the left anterior temporal pole, and the blackness of the white matter is missing on the left side. So do look at the anterior temporal pole, look at the blurring, and because if there is a temporal blurring, it needs to be resected along with the hippocampus. Look at the amygdala. Now, there are 2 different subsets. We can have MTLE with AS with amygdalary enlargement, or MTLE with amygdalary enlargement without a hippocampal sclerosis. And we have seen these 2 subgroups to be entirely different. A mesial temporal sclerosis with hippocampal sclerosis and amygdala enlargement, they usually suggest an early onset epilepsy, whereas a mesial temporal sclerosis with isolated amygdala enlargement without hippocampal sclerosis are usually seen in elderly people, and they respond very well to anticonvulsive medications. So like this is an example where you see bilateral mesial temporal sclerosis enlarged, which is seen bilateral symmetrically on both the sides. After you have found out one lesion, you should not stop at the hippocampal sclerosis or mesial temporal sclerosis itself. Try to look for the other epileptic lesions. Like in this particular case, we do see a left-sided hippocampal sclerosis with atrophy of the left temporal lobe and this dirty-looking white matter in the anterior temporal part, so might be associated with a type 1 FCD in this particular case. Or in this particular case, again, we have a left-sided MTS. This is quite evident, but if you see carefully, we have a malformation of cortical development, a gray matter heterotopia sitting on the left periventricular white matter. So dual pathologies are not uncommon. They are reported from 15 to up to 40% cases. So we should be careful to look into those etiologies. There are other epileptic lesions like a cavernoma. Sometimes you can have an epilepsy-associated tumors. I'm not going into it, but I'd like to highlight this entity called temporal encephaloceles, which are again not uncommon. We are seeing when the seizure is presenting in a middle age, a 30-40-year group, and we have the patient had a history of headache in past, and we find this kind of acquired temporal encephalocele as a cause of seizure. Now, moving ahead to FCD, we are all aware of this classification and the types of FCD, where type 1 talks about the radial and the tangential, abnormal migration of the neurons, and type 2 talks about the dysmorphic neurons with and without balloon cells, and type 3 talks about association of type 1 FCDs with other abnormalities like hippocampal sclerosis or tumors or vascular malformation. But this classification is getting expanded. Now we have genetic markers getting added to this cortical dysplasias, and we have new entries like a minimal malformation of cortical development, type 1 and 2, and MOGE associated with these conditions. Now, the type 1 FCDs, we have to be very careful to look in the temporal lobes. The type 1 is more common in temporal lobes, the type 1B is more common in the extratemporal lobe, and the imaging features can be subtle, from segmental lobar atrophy to white matter loss to cortical thickening. Type 2 FCDs, they usually present as increased cortical thickness with or without that classical transmental sign or the band sign, which extends a hyperintense extending from the malformed cortex to the ventricle margin. Now, if you look at this image, it is difficult to overtly make out, but we know that something is wrong over here, and we can see the cortex is slightly thickened. And when you look at this detailed corneal image, you can see that the gray-white matter differentiation is blurred. This is a type 2 FCD with the classical transmental sign extending from the depth of the sulcus to the ventricular margin. Now, how to find an FCD? Now, basically, we have to scrutinize the white matter gray matter junction. So, you should tweak your sequences to get the best gray-white differentiation accordingly. Look at the temporal and the frontal area at least twice. There are certain blind spots which harbors a lot of FCDs like anterior cingulate, insula, parieto-occipital sulcus area, and the orbital frontal area. This should be in your checklist, and it should be checked individually in both the hemispheres. Always use 3T unless you don't have it, and use the highest phase array coil that is available with you while scanning for a patient with FCDs or suspected FCDs. If you're not able to find, talk to your colleagues in the neurology, sit with them, discuss the semiology. If a PET FDG is available, look at the areas of hypometabolism, go back and then review your MR again. Now, MR negative epilepsies, which are seen in 20 to 30% patients, they will not have identifiable lesions on MR, and these are the unfortunate group because even if they are operated based on negative MR epilepsy, the chances of having a successful seizure control is around 46%. Now, what to do for all those? If it has not been done in the optimized protocol, repeat it, get it re-evaluated by a dedicated neuroradiologist, particularly after an epilepsy meet. That's a very good thing. When we discuss the case, re-evaluate with the background of PET, SysCom, MEG, and talk about advanced post. Regarding the advanced things, I'm a fan of arterial spin labeling. Like, I'm working on it for a long time now, and I believe it gives answer in certain cases. So like the last case that I've shown, that there is this source, the T2 stir, but look at the ASL. It tells you that there is some perfusion abnormality in the area of right frontal lobe. And this is one more sequence T1 edge, which is upcoming, and it is like, I find it quite great. You can see the junctional zone between the gray and white matter thickened in this area. So all of these are matching, and this leaves no doubt that this subtle abnormality on T2 is the cause of seizure in this particular patient. I did my thesis on in arterial spin labeling in the concept of periictal imaging. So after the patient has undergone video EEG and has had multiple series of seizures, they were taken back for imaging immediately within the 6 hours. And in this periictal period, we found hyperperfusion and hypoperfusion in multiple patients, which were helping in localized patients. So this is definitely a case of left frontal FCD. But if you see in the immediate periictal period, it is showing increased perfusion in the area of abnormality. And this patient, distinctly, there is a right-sided MTS, but immediately in the post-ictal phase, there is an hyperperfusion involving the amygdala and the head of the hippocampus. So these modalities can be used, and when we can reach in concordance.
Sarvesh, we need to stick.
Yeah, I'll just take two more slides, sir. Regarding morphometry, so there are multiple softwares which are available, which should not be used in isolation, but it can be combined with multiple things. Like in this particular case, this left MTS is there, and it gives a kind of value. If you can see the percentile values, when you have this percentile values, and when the values don't fall in the normative range, you can use them. can evaluate this in the background of clinical information. Just one more slide. These are the voxel-based morphometry analysis. This is the morphometric analysis program, and on the P1 imperiate sequence, you can generate this kind of cortical thickness map and junctional zone maps, which can identify the area of FCDs. Now, where this is leading to the use of T1 MPRH with AI-based models to automatically detect FCDs. So this is the program which is being currently used. And just a little bit about the MP2 rate sequence. Now, this sequence basically works by inverting the signal of the gray and white matter and highlighting the junctional zone, which harbors most of the FCD. So I'll just give an example of this particular case. On overt right-sided FCD, you find, okay, work is done, but on the epilepsy meet, it is found that this does not match with the patient's seizure semiology. We went back and looked at this scans. Overtly, it is very difficult to find the problems. We could see that there is certain abnormality here in the posterior insular area and in the left peridolandic cortex. But when you do the edge image, it highlights, it just stands out the abnormality in the posterior insular area and in the area of your postcentral gyrus, so epicentral gyrus. So this sequence is coming up in a big way in the neocortical epilepsies. I'll just skip this slide to summarize. Use a specific protocol. Clinical information is crucial. Make a checklist of different areas that you want to see in searching the lesions related to epilepsy. Take your time in reporting epilepsy patients. And patient with negative MR will benefit from a 3 Tesla, a second look, or a advanced imaging sequences. Thank you.
So, imaging in epilepsy in itself a very vast topic, and he has tried to summarize it in 12-13 minutes. Is there no, I can see a hand raised there. So please go ahead.
Thank you very much, Dr. Sarvesh, for that fascinating talk. Though we are in the sophisticated era of the 7 and 3 Tesla MRI, do you still feel there's a role for the humble CT scan in epilepsy imaging?
So CT, I think it can only be considered in acute setting when a patient presents with first seizure and the patient lands up in ER and we are doing the scan and we can find out a lesional cause of epilepsy, a tumor or granuloma or a mass effect that is causing seizure. But in a patient with drug-resistant epilepsy, when is considered a candidate for epilepsy surgery, it's rather be an MR than a CT scan.
Another question is that when you actually see the MR with a suspected FCD for the first time, do you like to be blinded to the electroclinical semiology and the history, or you see it after you through the light of the electroclinical semiology?
Yeah. Hi sir. Good morning, sir.
I wanted to ask you the same thing. Very good presentation. I think one of the greatest advances in neuroimaging is correlation with semiology and correlation with electrophysiology data. What you miss initially, so-called normal imaging, many things were found when you correlate. That probably what you meant by second look is not looking at MRI second time, but correlating with semiology and then electrophysiology.
Yes, sir. Yes, sir. So, sir, regarding that, I usually see the scan independently first, with the history second, and if I fail, then third time after with my colleagues to see if anything is being missed. Yes, sir.
Very nicely spoken. I just like to make a comment that there has been a silent revolution of imaging, particularly MRI in the area of epilepsy surgery, for the reason that earlier the lesions which were seen by radiologists or even neurosurgeons or neurologists were not thought to be significant. But there has been a lot of relearning when we again go back to the MRI, particularly after the stereoencephalogram. So when you do an SCG, we have seen many instances where we put an SCG lead, there is a very focused generation of epilepsy, and we go back and the radiologist even denies that there is any lesion there. But when we do surgery, we find that the histopathology is positive. And again, after the histopathology, when we go back to the imaging, the radiologist said, yes, there is something there, perhaps I missed it. So there is a constant learning. So from that perspective, I think the imaging has now we have become very sensitive, picking up very subtle lesions, particularly when we correlate with imaging, other non-invasive modalities. And particularly when we come back after an SCG, we become even more sensitive at looking at these very subtle images.
Agree, sir. Completely agree.
The second topic is basic pre-op investigations essential before going ahead with epilepsy surgery. And I call Dr. Manjari Tripathi. She is Professor, Department of Neurology, Aiims, Delhi.
Thank you, Chairpersons. It's really a pleasure being back in Aiims Jodhpur. This is a city where I spent the first 2 years of my life. My sister was born in the soil of Jodhpur during the war in a bunker. So Jodhpur has a close connect with my heart. So I have been given the responsibility of talking about pre-surgical evaluations and so what are the investigations which are needed, and I'm glad that Aiims Jodhpur has a strong team here with Dr. Samita, Dr. Mohit and others, the radiologists, Dr. Saurabh. So basically it's impossible to go through each case-wise description. So for the residents here, I don't know how many of you are residents. So if you really want to look at case-wise scenarios with about a 2-hour duration learning class of each case scenario, including the anatomy, mesial temporal, frontal lobe, we finished till frontal. We are going to continue with parietal and occipital and hypothalamic. This is the link to follow, and these are 2-hour sessions with 2 international faculty who have specialized in that particular topic, discussing case of refractory epilepsies. So it may not be possible to cover everything in a 10-minute talk. About 30% of people with epilepsy who come to our clinic will be refractory, and we know the definition of refractory epilepsy is those who have failed 2 anti-seizure medicines, irrespective of the time. But before we say that they are truly refractory, we have to take a step back and make sure that these are not pseudo-refractory, particularly pseudo-seizures or convulsive syncopes. And they're not pseudo-refractory because they've been started on the wrong medicines. It's a generalized epilepsy and they're receiving drugs for focal seizures. They have to be compliant, and they should have had a robust combination of drugs for a equal amount of time, which steadies their drug level in their serum and not change frequently the drugs. Now the key to fast tracking patients into investigative paradigm. Remember, anything you investigate for refractory epilepsy is very labor intensive. Even the MRI takes 1 hour. So before you have a knee-jerk reaction, sending them for an investigation, the role of CT comes up here. So most of them will walk into your clinic with a CT, and nowadays most of them are walking in with an inadequately done MRI. Some of them have not had a single MRI, they've had multiple, 5, 6 MRIs before they end up in the refractory epilepsy clinic. So if you find a structural lesion in the MRI and the patient is not responding even to the first drug, it's a high indication that this patient is going to end up being refractory, and you need to have these people on close follow-up. A higher frequency of seizures and focal seizures, presence of febrile seizures, presence of head injury, all this increases the odds of having refractory epilepsy to the tune of 20%, 20 times more. Now, having a home video, this is the next step. So the patient is having recurrent seizures. So when you send them back home, because your video EG list is going to be a little prolonged, you're going to have a wait list of 1 month or even 2 months, sometimes even 3 months. So please tell them to make a home video of the event. This helps you, formulate a hypothesis before they're connected to the epilepsy monitoring unit. So it also helps you rule out pseudo-seizures. So they must come back with home videos. I don't have time to show you the home video here, but many of our patients are now coming with home videos, and there needs to be a social awareness about this by your awareness lectures. Whenever you give awareness talks, you have to tell them there are only 2 things to be done during a seizure. One is the side position, and the second is timing the seizure, and of course making a video of the seizure. If they have intranasal midazolam, that's the only thing which has to be given. Nothing has to be given through the mouth, no onions and no chapels. So these things can be told to the patient as they're waiting for the video EG. Then of course, we can give them a list of questions in the local language. which helps them kind of go back home and look at if any of these things are happening prior to the seizure. Again, we are doing all this so that before they connect it to the epilepsy monitoring unit, we have a robust hypothesis from where the seizures are coming from. We can give physicians in our area or surgeons in our area or pediatricians in our area a quick tool for identifying patients who need to be referred to your center, say in Aiims Jodhpur. So if they have patients who are having focal seizures, who are having a past history of febrile seizures or a head injury and who have an abnormality in the MRI, these patients have to be referred by your referral network to you. So why are we doing all these investigations? The goal is, of course, to be able to get rid of the seizures. The goal of epilepsy surgery is to get rid of the seizures. It's not to get rid of the anti-seizure medicines. As a collateral, eventually you may be able to reduce the medicines down to one. Before you stop one, you really have to be very cautious. So the goal is essentially you have to convey to the people is to stop the seizures without producing any additional deficits, whether they are cognitive or motor. Now for that, it's very important that in the investigations we know why we are investigating things. So there is what is known as the structural lesion, which is the structural zone or the lesional zone. The lesional zone is very, very important because if you have a lesion, automatically the outcome of surgeries improves. Hence, the radiologist is the key member of the team who identifies the structural zone or the lesional zone. But it's not just the lesion. The lesion itself, the center of the lesion may actually be dead. It's the area around it which is epileptogenic, and hence the role of the neurologist is to identify this zone, which is the ictal onset zone. So ictal onset zone is the zone which is giving the origin of seizures, and this is defined by your ictal video EEG, ictal SPECT, and of course an ictal MEG. So that gives you, and the ECG if you do it. So that gives you the ictal onset zone. But there is something known as the irritative zone, which is a wider zone, and the zone is like the smoldering coal in a fire. The fire is not out, it's not burning, but the smoldering coal is burning at odd spots. And this zone is known as the irritative zone, and this is defined by our interictal investigations like the interictal EEG, the interictal SPECT, the PET, and the interictal MEG. So this is the irritative zone. The role of the neurologist in the team is to identify the minimum amount of tissue which needs to be removed to make the patient free without producing deficits, which is known as the epileptogenic zone. This epileptogenic zone does not have any hard markers. It has to be derived from a number of investigations which you have done on your particular patient. Now, in any center, the first, which is the clinical, the home video, the narrowing down of the symptoms which occur or the signs which occur in the seizure, the video EEG semiology, the video EEG ictal onsets, and the interictal. This part of it, along with the MRI, is the basic investigation. Most centers should start out with these investigations for simple cases. If you're just starting a center, it's better to go with these simple cases first because the outcomes are going to be better, which helps you build up the confidence for going in for more complex cases. And of course, you need a good neuropsychologist to give you a balance of what function is there and what function is lost. So if you have all these available, you are in a tier 1 center and you can go ahead with surgery if all investigations, particularly imaging and ictal onsets, are concordant along with the semiology. If there are red flags in the semiology, like you have symptoms like a mesial temporal sclerosis, but it's preceded by an auditory or visual aura, then these are red flags. Here you will have to look for other, sources of origin and propagation to the temporal lobe, which is not uncommon. That is known as the pseudotemporal or the temporal plus epilepsies. And epilepsies coming from no man's land like the insula, the precuneus, the cingulate, where you can have propagation to varied areas of the brain. So that's where you would probably require better neuroimaging, functional imaging like PET or MEG or a high density EEG, and in some cases a stereo EEG, which of course are possible in a tier 2 or a tier 3 center, particularly if you're doing stereo EEG. For all this, you need to have a team, you need to have a team which is dedicating time and spending time together. So for us, a Monday afternoon from 3:30 to 4:30 or 2:30 to 4:30 is the time where we discuss our cases and counsel our pre-op patients. So this has to be done regularly. It cannot be just, discussing in the corridor or discussing just in the neuroradiology conference. So really you need to have the team come together at some point of time so that we can decide if there is a lesion which is producing that abnormal network and that lesion needs to be removed, which is the resective surgery. And of course, we can decide whether it's not worth doing a resective because it's a more hemispheric problem in which we do disconnective surgery, or a bilateral problem in which we'll do a callosotomy, or we don't want to do either because the patient is very old and we go ahead with modulation. It's very important to remember that semiology is not everything. You can have propagated seizures, so the seizure could originate from the occipital lobe, from the parietal lobe, and propagate through the longitudinal fibers to the frontal lobe and produce frontal lobe semiology. So semiology is not everything, particularly in children where you can have generalized seizures for focal lesions, and you can have a large hemispheric lesion with a generalized EEG onset or bilateral EEG onset. So I think my time, is that my time which is ringing there? What was the bell? Okay. So I will not waste much time here, and I will just go on to show conclude by saying that there are guidelines available to us as to which investigations are mandatory. That is, H is highly recommended, O is optional, and L is little use and U is uncertain. So wherever you have a mesial temporal sclerosis, a DNET, a type 2 dysplasia, which is concordant with your semiology and your video EEG, you can straight away take away for surgery, as I said. But however, wherever you have a normal MRI or subtle lesions on the MRI or discordance between the video EEG and the MRI or multiple lesions or a surgical failure, there it is highly recommended that you do additional investigations like MEG, which is available in our country, high density EEG of 128 channels and more, which is available in our country, and intracranial EEG placements, which is also available in our country. So that would be focal cortical dysplasias type 1. It would be MRI negative patients, as I said. It would be patients in whom you want to define function. It's near a eloquent cortex like the comprehension area or the Broca's area or the visual area. Again there. And it will also be in patients who have multiple lesions like tuberous sclerosis or multiple gliotic scars. So I'll conclude by saying that it's worthwhile reading this paper because this is a statement by the International League Against Epilepsy. And, go ahead investigation is concordant. There's no point doing an ictal spect in a patient where semiology and video EEG is concordant with the lesion, because you may get some discordance in that which will confuse you. So plan out your investigations and investigate patients accordingly. Thank you. Again, I have not been able to cover the cases. So I would again request all of you present here to go back to this link. You can take a photo of this and you will be able to see all the cases like right MTS, left MTS, DNET, dysplasias of the temporal lobe, frontal pole, dorsolateral frontal, basifrontal, motor cortex. So we've discussed almost everything in these series, and this series is ongoing. Thank you.
So any questions? So if you have any questions, you can always ask ma'am. She's around, and a fantastic talk, ma'am. Thank you so much. And we know this looks like an ongoing process. So we are all evolving with our pre-surgical workup and also epilepsy surgery and surgical management of epilepsies. So thank you so much again. And I now invite the next speaker, who is Dr. Nilesh Kurwale. He's from Dinanath Mangeshkar Hospital, Pune, and he will talk about what is the optimal in MR negative epilepsies, invasive or further imaging.
Good morning, and I sincerely thank the organizers for giving me this opportunity. It's a wonderful meeting. So today, my talk is MRI negative epilepsy. What is optimal, invasive or further imaging? So I will be covering like fundamental differences between the imaging and invasive, literature review on outcomes, supporting data and interesting facts which I collected, what we do and what are the technical details. That would be simply thing. So defining MRI negative. The first scenario is reported negative by a radiologist surgery scan without access to any clinical data, just on a historical basis. Negative by radiologist who has having seen reports. These are scenarios which I commonly find in my practice. And third is reported negative by radiologist present in the epilepsy surgical meeting. So these are MRI negative for me. So what are the options? We have intracranial EEG, practically stereo EEG, and other is a further imaging or a post-processing. Now, if you again, I'm trying to now go for a differences in the stereo EEG and imaging. What are those differences and how we should, kind of invest. So stereo EEG, if you look at the literature or if you look at the evolution, it evolved when imaging was in infancy, in the CT scan era, after CT scan era, pre-MRI era. So they have only access to electrophysiology and nothing else, and that's where that was evolved. And it was again evolved primarily through focal cortical malformations. Now the pathologies are different. We are using it for many pathologies, but it's primarily evolved to focal cortical malformation. And imaging actually evolved since 2000, and power of mathematical computing gave imaging a lot, a different age where which we are experiencing. Interpretation in stereo EEG. Now stereo EEG, we'll have different waveforms. Those are kind of signatures, sometimes they are not. So there are 5 or 6 type of waveforms and semiology. So many a times, inter-observer agreements are very difficult to reach in semiology. And that is the reason they will involve more and more number of areas and more, outcome-wise. So imaging, however, it's completely objective. Apart from 10% of the cases, 90%, if you show the imaging to 2 radiologists, most of them will agree. So that is where it comes from. Now coming to the resolution of a stereo EEG versus imaging. We all know that minimum electrodes that we put generally in a theme implantation, perisylvian, temporal or all, so approximately 9 to 10. After the agreements on semiology, they put generally 10 to 12 electrodes. Even then, the distance, minimum distance between the 2 contacts is 2.5 centimeter or 3 centimeter. And then it keeps on 2 electrodes. And then after that, when you evaluate those waveforms, it's very difficult again to reach to those agreements that which exact electrode is firing and where exactly is the onset, unless you hit the bullseye, which is generally not the case. And recording volume of inch contact is very less. Compared to imaging, imaging gives you a resolution of 1 by 1 by 1 millimeter. That is the best resolution possible for any kind of diagnostic test. Now, learning curve. In stereo EEG, generating a pre-implantation hypothesis is a big task because we are putting some electrodes inside. Then seizure onset, early propagation, early seizure organization, all these terms are evaluated or evolved because you want to try to maximum because you do not have anything visuals. You try to extract everything out of the electrophysiology and semiology. And again, agreements cannot be reached. And that is the reason you try to be inclusive of everything so as to achieve the maximum outcomes. And that is how you formulate the resection plan. However, in imaging, you get a clear-cut focal cortical dysplasias as previously a speaker has highlighted. So, in stereo EEG, you have a broad plan compared to in imaging, you have a very fixed plan. Extent of resection. Now, in stereo EEG is generally an indirect targeting. That's what I normally say. For a surgeon who is supposed to know something for what to resect, this is what happens in stereo EEG. He is given some task of indirectly interpreting and taking it out based on some indirect inputs. He doesn't have a visual inputs on what to resect, as we surgeons are all trained. So another thing is, and because of this more and more inclusive nature of formulating a plan, large areas are included for resection. And generally, many a times, when you, this is exactly what I feel, this is from my experience in stereo EG, we generally shoot across the bladder, and you may just end up shooting blindly without getting anything, or you may get a very small target and involve large area of resection. If you attend a stereo EG conference and find out and look at the post-operative scans, most of them are for a large lobar resection. Unless the stereo EG is put for a proving the hypothesis that you already know you have some visual and you put an implant to prove your hypothesis. Unless in that case, in a completely truly negative cases, the resections in stereo EGs are way more than what it is. And why we are at the first place, why we are doing stereo EG? For a subtle pathologies, most probably bottom of sulcus dysplasia, and which are generally supposed to be gyral lesions. So for small gyral lesions, when you put a stereo EG, you end up doing large resections. And there is always a downside of large lobar resection in a completely functionally preserved patients of epilepsy surgery. On the contrary, imaging gives you a very precise focal definition of what to be resected. It's like a bird's eye. So that's my understanding of stereo EG versus imaging in resective plans. Now, this is the outcomes. The first paper is a stereo EG based outcome from the best center in the world, that is Cleveland Clinic. I quoted a generous paper again for the stereo EG here. The general outcomes quoted are between 35 to 48% for MR negative epilepsy. But this paper, I indirectly got the outcomes. It is 60%. They are saying 60% are seizure free, not having recurrent seizures. Compared to a very landmark paper by Dr. Simon Harvey group, 88% patients are seizure free at 4 years when you identify bottom of sulcus dysplasia on MRI and post-processing. So these differences speaks for itself, like 88% versus 60%, and mostly pathologies are the same because primarily we are looking for a focal cortical malformations. So if you exploit more and more imaging, your outcomes are going to go more. Now coming to the complexity, we all know stereo EG requires a lot of setup, lot of training, lot of costs, and the time is huge, 6 hours, and then interpretation by a neurologist, which is another task. Although it gives you a lot of other inputs, but to go early to the outcome base, this is too much to invest, too much to get, and the cost is huge. One electrode will cost you 1.5 lakhs and so on and so forth. And stereo EG is beyond reach from most of us as a programs. So compared to imaging, very easy to set. Most of the time, 3 Tesla MRI is available. You just need to tweak few sequences. Time is very limited, and post-processing requires just a small workstation which costs you more than, close to like 2.5 to 3 lakhs rupees. So the idea is, another last thing, this is, by doing a post-processing, we identify these small lesions, which generally are not possible. Small lesions are generally not possible to identify. Even if you put stereo EG base for these lesions, you would end up resecting way more brain area because you would include the seizure propagation zone, early seizure organization, so on and so forth. So by resecting this small area, all these scans, patients are seizure free for more than 3-4 years and they're off the drugs now. I selected those scans. So the idea is imaging gives you much more power than stereo EG. Coming to that, we have some data, interesting data, to understand it better how MR negative epilepsies come to us or show us. We conducted a small study in our setup. We have an epilepsy surgical meeting. So we operate all the dysplasia. So what we collected is all operated patients of dysplasia where biopsy is positive. And then we collected the MRI report, what a radiologist and a PET nuclear medicine guys reported it previously before having access, and all of them histopathology was available. So we reported we differentiated into classes. Positive report by a radiologist means they reported the same dysplasia which we operated, biopsy is positive. Negative report means they did not find anything. Discordant report means they reported something and we took out something and biopsy is positive. So these
Dr.
reports are also,
Kurwale, sorry to interrupt, but
oh, yes,
the time is up here.
Okay, so just to conclude, in our setup, for last 8 years, our radiologists are exposed to this MRI and reading. Only 50% of the MRI reports were actually reported what we took out. in surgery and histology positive. 25% are discordant, they reported something else, we took out something else, and 20% we couldn't find anything. So that is a kind of field if you do not have access to all these things and post-processing. So it means if we are not exploiting the imaging, all these another 50% we will probably be implanting, or if not 50, another 30%. So the idea is here, what we do, I think I will, so the idea of this presentation is, now if I am a young program, I want to invest in something. So should I invest in a stereo EEG or should I invest in an imaging? So I would put a point that we as all young people who wanted to get into it should invest more and more into imaging, because you can cut down on stereo EEG by a large volume, and that is what we as a country require. I mean, as a because most of our patients come from not so affording background. Thank you very much.
Thank you. Do you have anybody? Sir, please.
Nilesh, very nice presentation. Now, very nicely put points, but I just like to reiterate, SCG, when it was developed 3, 4, 5 decades ago, mostly in Europe, it was more like a religion. They would do EEG and they would directly go for SCG, and there are cases where they wouldn't even do MRI. So the current SCG, what we are seeing globally is completely different. And the pattern which I think will develop in India again will be totally different. So we have evolved SCG into basically at two levels. The first level is to prove a hypothesis. So we do all the imaging and we find that there is some pathology, we are not able to kind of catch hold of it, but we are kind of suspicious that it is there, and now we want to put an electrode and prove it. That is where we put an SCG and we prove it and we find that it is there. It becomes a learning for us, it becomes a learning for the radiologists. So that's the first level, and this is where we started, learning from SCG. So we would do all the non-invasive investigations. We will try to look for an hypothesis. We will develop a strong hypothesis, and we are kind of almost sure that the lesion is there. It's like a shadow, but we are not seeing it completely. And we put an SCG electrode and we prove that it is there, and we do a resection. It comes to positive, it increases the confidence of the whole team, and we progress ahead in our learning. That's the first level. And in our experience of implanting more than 300 electrodes, we find that the mean number of electrodes are around 7. With 7, we are able to do it. Then the second level is, and when we do it, when we do the SCG, post-SCG, when we burn it, 20% we with burning, so we don't have to do surgery. When we do a resection, again we do an echo-guided resection, which is not done in places like Cleveland. Once they put an SCG, they don't believe in doing an electrocardiography. But we do an electrocardiography so that we can tailor the that we have found is developing very nicely. I mean, we are able to get very good results with ECOG mapping. The second is to prove a hypothesis. I think this is very, very difficult. And this is where we should be very cautious, especially for people who want to do it for the first time. For the simple reason that if we put an electrode, which is just 0.8 millimeters, we have to understand that it is sitting over 1 million neurons. Neuron is connected to 10,000 neurons. And these can actually record the signals from the ECG. So the second part, we have to be very, very cautious. I will not advise anybody to get into that, because you will end up putting a lot of electrodes. The results are not going to be so good. You're going to spend a lot of money, and ultimately you may not get anything out of it. Sorry if I was a bit long, but I thought I should.
That was a great comment, actually. It's more of complementing both the things. So, but he basically stressed on the fact that if you want to invest as a young, program, it's worthwhile. But then, sir made a great point. Yeah, please. It's actually complementing.
It is. I think the essence of this presentation out here is something which needs to be understood. I don't think it is this. The essence of this presentation is to try and do in what restraints you have, what constraints you have. The country cannot have a full thriving SEEG program. And I think that's exactly what Nilesh is probably trying to highlight, and it's a much easier tool at hand, and post-processing is something which is possible with good expertise and a good MRI imaging, which a 3 Tesla machine is possibly available at every city possibly now. So I think we need to try and understand that the discussion is probably not the utility of SEEG versus MRI scan, but the ease of running a center with a good epilepsy surgery program, just using techniques which are much more in a city. I think that's probably what we're talking about. I hope that.
Thing, but I thought people to have like in recent conferences, most of the time I get feel that all the younger people are they just want stereo EEG to find the answer. This is not the case. Stereo EEG, we have done around 40-45 stereo EEG so far, having put more than 500 electrodes so far. But most of the time it creates problem for me than the answers. That is my own experience. Although it's very less, but still it's the experience.
So thank you so much. In fact, there's no time now left now. But then, yeah, so great session. And thank you all these speakers.
We now move on to the next session, that is a panel discussion titled Do We Need Invasive Monitoring for the Management of Complex Drug Refractory Epilepsy in Resource-Constrained Settings. I would now like to call the moderator, that is Dr. Nilesh Kuruvale, consultant neurosurgeon at Deenanath Mangeshkar Hospital, Pune, and the panelists, Dr. Malla Bhaskar Rao, Professor of Neurosurgery at Newmans, Bengaluru, Dr. Manjari Tripathi, Professor Neurology at Aims Delhi, Dr. Sarat Chandra, Professor Neurosurgery at Aims Delhi, and Dr. Milind Sangre, consultant neurosurgeon at Hinduja Hospital, Mumbai.
So good morning. So I will be with my laptop. So this session is all about discussing again the pros and cons of stereo EEG, invasive, or highlighting when to do which investigation. And we have esteemed panelists who will be talking about pros and cons, and it will be a more or less like a discussion between these topics. So to start with, Rao to introduce the topic, and he would be talking about invasive monitoring.
Good morning. Thanks for the opportunity. So the issue of invasive evaluation has got many debatable points. So I'll give you some idea, mostly from historical point of view, how things evolved, so that the panel discussion will give you useful information. When epilepsy surgery started at the Queen Square, London, the surgery was lesional epilepsy surgery. Sir Victor Horsley performed resective surgery based upon the clinical localization provided by technology, correlated with electrical stimulation of the cortex in primate experiments by Sir David Perrier. Even when the epilepsy surgery was restarted at the Montreal Neurological Institute, Penfield did lesional epilepsy surgery, mostly in post-traumatic cases. Again, depending on semiology, cortical stimulation using electrocorticography, and whatever imaging was available those days, pneumoencephalography, angiography. In fact, Penfield used it to abandon surgery if there is no lesion. So it was heavily anatomical, lesional guided surgery. There is a shift in focus from lesional epilepsy surgery, identifying and resecting the focus. That was facilitated by the invention of EEG by Ansberger and the Gibbs couple who described the classical electroencephalographic patterns in temporal lobe epilepsy. Of course, the resections were carried by Dr. Bailey in the United States. By 1950s, mesial temporal sclerosis has been established as the most common substrate of progressive epilepsy, and anterior temporal resection became a standardized procedure. So there is worldwide interest to identify people who have got the MTLE with MTS syndrome based on Faulkner's standardized surgical resection. So there were a lot of efforts were going on in how to identify ideal candidates. So the nasopharyngeal electrodes were devised, tympanic electrodes were devised, foramen oval electrodes were devised. But it was realized that the gold standard is recording directly from the brain. So there is a neurosurgeon at Oxford called Reginald Bickford. So he had a patient who had a bullet injury, and along the bullet track he has implanted a depth electrode into the brain and recorded electrical activity. Of course, subsequently this Bickford moved to Mayo Clinic in 1950s, and then there he started implanting Warhol and then freehand implantation of electrodes to record electrical activity directly from the brain. Of course, again there is a shift from lesion to focus to network by the pioneering effort of Talaric and Bancot in Paris, and the French and Italian groups came with this stereo EEG in 1950s. According to the French laws, the recording was feasible only for few hours. So what they recorded, the initial stereo EEGs are only few hour recordings, mostly interictal activity, occasionally with electrical stimulation, or also by giving convulsant medication, they use it to record a few ictal events. The long-term depth electrode recording started actually in UCLA by Paul Crandall in 1960s. So Crandall effectively used the available knowledge of those days by implanting depth electrodes and then getting the electrographic pattern of the seizures, and then using not only seizure onset but by micro electrode recording so that the unit potentials, field potentials, all those things eventually were correlated with the resected specimen. They used it to do en bloc resection at UCLA and then correlate electrographic and basic science and histopathology. And then actually Paul Crandall's work at UCLA became a ground for multidisciplinary research in epilepsy surgery. Of course, in 70s and 80s, the electrocorticography work continued, and the invasive evaluation both by depth electrodes as well as stereo EZ continued. And then there is an advent of a third initiative at St. Louis University by Sidney Goldring. He used to implant epidural pegs first and then grids next, and then that work, Sidney Goldring's work, eventually became the subdural grids and strips, hugely popularized by Hans Luders at the Cleveland Clinic. So all these invasive evaluations have got advantages and disadvantages. You can precisely identify the seizure onset as well as propagation. Of course, no muscle artifacts like the non-invasive evaluation. Of course, they had risks, and then very limited sampling is done, and then of course. In India, for our panel discussion, cost is a big factor. So, because of the implantations, especially stereo EZ, high frequency oscillations are being recorded from these electrodes, and the high frequency oscillations became like a summated action potentials of this synchronizingly bursting neurons. It became like a biomarker to identify the seizure origin areas. Within the focus there is origin, within the lesion there is an origin, within the network also there are specific areas are there. And then therapeutic interventions came to address these origins. One is, for example, there are radio frequency ablations are there, and then now laser ablations are being done at the seizure origin focus, and even non-invasively also we can identify these high frequency oscillations. This is a work done at NEMHANS using MEG to identify these high frequency oscillations so that some sort of ablations can be done. For those of you who are interested in invasive evaluation, this is a very good review article by Dr. Jaikar. So I got what considerations will lead your decision to make stereo EZ, what are the indications, what are the types of implantations, what are the advantages and disadvantages of all these things. I'll just leave you with the two this is Laura Zehi at Cleveland Clinic published this work. She studied during the last 2 decades across 6 very prominent epilepsy centers worldwide, and she found that epilepsy surgery is going on steadily in all these 6 centers. Surgery for mesial temporal sclerosis is coming down, but the implantations are going up. Implantations which are not leading to resective surgery are also increasing, because probably once implantation is done, data is there, you can consider ablations, or you can even consider implantations of devices like RNS and other options. So this is worldwide trend is increasing for implantations. And I'll just leave you with one thought. This is an old paper published at among 214 patients were drug-resistant epilepsy. They were not, after initial evaluation, their further intervention was not carried out, and then why it was not carried out was published. So they had, this of course, this is an old paper nearly 2 decades ago. So MRI is normal, and then they are not able to afford invasive evaluation in India. Now stereo EZ is expensive. Post-processing, of course, we have to see how many people in India will be able to spend that much of, because a normal level versus with how many will be picked up in normal MRI. So these are all issues. Maybe now we can start the discussions. Thank you very much for our opportunity.
Yeah, thank you very much, sir. I invite you here to please have a seat. And we can take the discussions forward. So just to save the time, I think I will I would ask Dr. Manjari Madam. I will hand over the mic. Sorry. So, what is generally, I mean, what are your indications for invasive? When do you consider invasive imaging, and what is your threshold of imaging versus invasive? What is that boundary where you to consider no post-processing is not enough here, or I think we should go for invasive?
So our threshold is very, very high. We always approach a patient with not an invasive case. So that is our motto. So for achieving that motto, first we have to have a high throughput of the non-invasive investigations, which would indicate, looking at the semiology and the ictal onsets of all the seizures which are captured. Now in complex patients, you can't just capture one seizure and say video EG ho gaya hai. You have to understand whether the patient has a single seizure type or multiple seizure types. If there are multiple seizure types, obviously the location of the lesions becomes either insular or precuneus or cingulate or whatever. So first you isolate at the clinical level, then you look at the ictal onsets of 3 or more than 3 seizures. So there's no point going in for a SEEG if you haven't even looked at, say, 5 to 6 seizures of that patient, ictal onsets. Then of course we go in for the MRI. Now let me tell you, it's very, very disheartening to note that nobody spends time with the MRI. So any center which is doing MRI, say, for 3 Tesla for 6,000 to 12,000 rupees now, they haven't done a 1 millimeter protocol. They've done 4 millimeter or 5 millimeter or, whatever. They haven't done the proper harness protocol. They haven't done ASL, they haven't done a SWI, they haven't done a 3D acquisition of T1, T2. So whatever it is, it's highly inadequate. So we are failing at that first step, which is to have a very good MRI. Even the acquisition, forget the post-processing. So if you have to do post-processing, the acquisition has to be perfect. I do not think there are many centers right now in India which are doing a perfect acquisition MRI, which is epilepsy protocol. Maybe few centers like, Aiims, your center, Aiims Jodhpur, where the radiologist is interested. So essentially you have to have a radiologist who's interested and who's giving time to the patient. And believe me, one epilepsy protocol MRI takes about an hour, minimum. I don't think private sector, I'm sorry, but, on the street private center of MRI, I'm talking about isolated MRI center, not a hospital setting, is going to give that kind of time for doing an MRI which is of commercial interest to them. So really you need to work in a center, or you need to be in an institute, whether it's public or private, where you are giving that 1 hour to that patient when the acquisition is going on. Because if your acquisition input is not good, your output is not going to be good. Then of course post-processing can be done by various softwares and techniques which are available. In patients where the MRI is normal and you've gone back and looked at the electroclinical correlation with the MRI. So if the MRI is normal, we go back, the first discussion would be go back, look at the semiology, show the ictal onsets to the neuroradiologist and tell them, hey, it is coming from FP2, so please look at the right frontal pole. So we try to do electroclinical imaging correlation. If that fails, of course, we have to go ahead with advanced investigations like an ictal SPECT. Now, ictal SPECT has to be injected within 30 seconds of the seizure onset. We've come across ictal SPECTs done outside for 15,000 rupees and the injection was given half an hour after the seizure. So it's no more an ictal SPECT. So you really need to do a good within 30-second ictal SPECT, interictal SPECT, PET. And now we do have high density EG. We are doing high density EG of 128 channel with BISA source localization. We are doing MEG. So there are 2 centers having MEG, our center as well as NIMHANS. Now, invariably this kind of patient who has a normal imaging or a subtle imaging or post-surgery failure or multiple lesions will have 5 or 6 discussions in the pre-surgical meeting. It's not going to end up with one discussion. So even before you put the SEG, all effort is in these 5-6 discussions, are we able to crystallize where the epileptogenic zone is and the hypothesis is? And if we feel that it is a normal temporal lobe structurally by MRI, but the PET is showing a hypometabolism, the ASL is hypoperfused, the ictal onsets are there, but structurally the MRI is normal, and the MEG is also there, we go ahead without an invasive in such patients unless there is some red flag in semiology. So our threshold for putting as SEG, believe me, is very high. We have a randomized control study going on where we are investigating patients for SEG with few electrodes versus more electrodes, whether there was any difference. So all effort has to be made to try to localize and find a structural lesion by various methods before even thinking of a SEG.
So I think you clarified the point very well. So the second question is probably for the surgeons. What is our comfort level in surgical resection or surgical plans when you are operating based on the stereo EEG based inputs versus the imaging based inputs? Just your experience, I mean, what do you feel, which one, like how do you manage all those things?
So, see, what is a strong point for a surgeon? The anatomy. Now, if you are given an anatomical target which is supported heavily with imaging, and every epilepsy surgeon is extremely comfortable with the use of navigation, with the use of an MRI scan, and if you're pointed out and you're given a target, and MR guidance is much easier from a surgeon's point of view. Having said that, that does not mean that you should not really have an understanding of what's happening on the EEG or an SEEG as far as epilepsy surgeon is concerned. Overall, as a surgeon, I can understand why a surgeon is much more comfortable purely with an MR targeting. But to say that we will only do post-processing and not have a role probably is equally not true. There is a definite feeling that we are all going towards an SEEG as an overkill and trying to compensate for inadequate workup, as Manjari was mentioning, by putting in multiple electrodes. From a surgeon's point of view, I practically feel that it is much easier to go with an MR targeting. I suppose that would be.
Nilesh, I don't know if it's appropriate. I have a 5 minutes video. Do you think I could show them, or we don't have time for that? Restriction. So fundamentally, I would say that our SEG program, when I discuss with other international centers, or I discuss with Cleveland Clinic, or I discuss with other people, is evolving in a very, very different way. So we have analyzed and found that the mean number of electrodes we put is around 7. And we have found that whenever we exceed 10 electrodes, we have kind of lost the hypothesis. That's the first thing. Then the second thing is, as Manjari was mentioning, we need to have a very strong hypothesis. So unless we have a very strong hypothesis, like I was mentioning in the stage 1 of SCG, we are very sure that the lesion is there, but we are not 100% sure on MRI. And if it is temporal, we still go ahead with the direct resection. Extratemporal, we would always like to do an SCG and proceed. That's the point number 2. Then point number 3, we do a triad of confirmation of the networks. So first, we get a spontaneous seizures. So this is mandatory. We do it for all. We have done it for all our SCG cases. So there are no exceptions to this. So first is we record spontaneous seizures. That's the first thing. Second is we stimulate and produce habitual seizures. If you are not able to produce habitual seizures, that means we are missing our hypothesis. And point number 3 is we do a radiofrequency ablation of the SCG electrodes. Now by doing radiofrequency ablation of SCG electrodes, we have got away in 20% of our cases as a standalone procedure. We didn't have to go ahead and do a resective surgery later on. But in 80% of the cases, what happens is the seizures dramatically reduce. And we go ahead with surgery after a couple of weeks, once the leads are explanted. What happens here is when the seizures dramatically reduce, it gives a huge element of confidence to the patients and the attendants that yes, we have hit the spot and we do the surgery and it is going to be successful. And it also gives a large element of confidence to us also. Right? And finally, last but not the least, this is what I found, that we are evolving in a very different way from the SCG which is done in the West. Is that once we localize, because we don't put too many electrodes, once we localize where the networks are, we do the final resection using electrocardiography. Now if you look at our papers in electrocardiography, we have had experience in more than 1500 cases. And we find that in most of the cases of SCG, we get very good preoperative ECOG recordings. The reason is that most of the SCG cases we do are MRI negative and there is a subtle cortical dysplasia, and all of us know that ECOG works very well for cortical dysplasias. So that is why an ECOG guided resection, pre-op, multiple post-op recordings, till we come to grade 1 really works out for us. That way, we know where to do an ECOG guided resection. So by using these 4 verticals, we have, till now we have achieved, I would say, about 60% of our MRI negative patients have become seizure free. So we have been able to get a very good outcome. And these are the patients, when I say MRI negative, these are the patients who had undergone something like 12 MRIs. They have been seen by multiple physicians all over the country. And they have undergone multiple imaging, practically every imaging every 6 months, on 10-15 drugs, and then they have finally come to us. So the pattern of SCG, I believe, is still evolving. But I think in our center, we are kind of very comfortable with evolving of this pattern, and looking back, we have a great deal of satisfaction that we are on the right path.
So, yeah, sir, thank you very much. Another set of questions more or less related to the same thing. So, CTVG has different indications, like one is completely negative, you don't know anything, you are just putting based on the semiology and trying to find out what it is. Very focused semiological input. And the other is like you want to prove the hypothesis, like you have some suspicious areas, looks like this, looks like that, and patches. So what percentage of your stereo age implantations, maybe in last whatever in practice, goes for first reason that you have absolutely nil on MRI versus proving the hypothesis that you have some suspicion on the MRI and we want to prove it for all of us. Like, this question is for.
So with the permission of other panelists, can I take this? So that is a very relevant question, Nilesh. So here I would like to tell you that the definition of MRI negative itself is changing. The goalposts for MRI negative imaging, so-called MRI negative imaging, is changing. And I think there are 3 categories of MRI negative imaging. The first category is we do see some subtle lesions. It could be gliosis, it could be some kind of, some lesion there. So this is actually not truly MRI negative, but we say that the lesions are not corresponding to your networks, or you want to prove that these lesions are corresponding or not. And that is when you go in for an SCG. The second category of MRI negative is when you do all the imaging, the radiologist says that it's absolutely negative. You do more advanced investigations and then you come back and then you're able to pick up a lesion. And again, you do all the necessary investigations. So let us say the MRI the radiologist says completely negative. But the ictal spect is pointing out to the right temporal lobe, MEG is pointing to right temporal lobe, there's a hypometabolism on PET in the right temporal lobe. So everything is concordant. Now here 2 scenarios can arise. The radiologist, once you sit with them, he or she can say, yes, I'm finding some lesion. So maybe you can go in directly for surgery. Second scenario is you put in SCG electrodes, you go back again, and then a completely MRI negative picture evolves as an MRI positive. So now we have to understand that the goalposts or definition of MRI negative itself is changing. The third scenario is truly MRI negative, which means the MRI is nothing contributory, the ictal spect is nothing contributory, the PET doesn't again show anything, the MEG again doesn't show anything, the semiology says maybe projects to frontal, but again nothing on this. So here none of the investigations is concordant with anything. So I would say this is a true MRI negative. So at this point of time, I don't think these patients can be offered treatment anywhere in the planet. And they have done such patients in Cleveland where they put something like 30 electrodes and they have all turned out to be negative. And nobody wants to speak about this group of patients, where everything is discontent. Can we put 20, 30, 40 electrodes and then get something positive, which is very, very unlikely. So your question is very relevant in the sense that we have to now define what do we mean by MRI negative. So from that perspective, it is changing.
So to answer your question, most of the time, if we find a lesion and there is a subtle lesion and it follows the type 1 dysplasia, description, very often if everything is concordant to that spot. For example, just last week we had a young girl who came all the way from Rajkot in Gujarat, and she had a subtle lesion in the left angular, just above the left angular gyrus. And everything, including SPECT, PET, MEG, was concordant with that. We don't put in an SCG electrode, we just remove it. But however, if everything is normal, but investigations are concordant to one spot, tight spot, we go ahead with SCG placements, which are nominal in number. But if everything is dispersed, and we are not getting a good hypothesis, we don't even bother. There's no point putting in so many electrodes and trying to, then we look at genetics, we look at diet. There are other optional therapies. So we know modified Atkins diet is very good. So we give them a diet, exposition to the diet of 6 months or so. And then re-look at the case later. So we don't rush. What I mean to say is we don't rush into SEG with such patients.
I was trying to ask the percentages so that the audience can get a perspective. But yes, I think we are coming to the end of this session, and I will try. I
was just going to.
In pre-surgical evaluation, there are two beautiful words are there. One word is concordance. Second word is redundancy. We should try to understand problem. All modalities will give some information, whether they are matching or not. Suppose if MRI shows right hippocampal sclerosis, either Schizer semiology and Schizer onset electrically, is it from the right hippocampus or not? That is the concordance. And to establish concordance, you have to do what is minimum required. Suppose if Aiims Jodhpur has got stereo EZ and all program, all should not be used in all patients. What is just basic minimum required? That is the redundancy. If you follow the principles of concordance and principles of redundancy, you can optimally utilize all available facilities. That sounds maybe, Sarath is the president of the Indian Epilepsy Society. I am the president-elect. Dr. Manjari has been involved for decades. I think maybe all these professional organizations can come with some sort of guidelines for implantation, because there's going to be explosion of stereo EZ in India in the next 1 or 2 decades. Most of the young people will take it up because it looks like that's the international trend and way forward. So I think we should have a national guidelines. Again, these guidelines are suggestive, they're not binding. So people may take, may not take. So parallelly, imaging also will make progress. These are like twin tracks. Both are making progress. And because of this progress, we are taking more and more difficult cases. And then again ending up with more difficult problems. So I think that is the natural progression.
So, thank you very much, sir. It was a nice discussion, and thank you very much for giving all your inputs. I close this session. I declare the conclusion of this session. Thank you very much.
Thank you for moderating, Nilesh.
Thank you to all panelists and the moderator. We move on to the last session of this conference. This will be dealing with the operative techniques in epilepsy surgery. For this, I invite the chairpersons, Dr. Mallabhaskar Rao, Professor Neurosurgery at NIMHANS Bangalore, Dr. Milind Sankhe, Consultant Neurosurgeon at Hinduja Hospital, Mumbai, and Dr. Manjari Tripathi, Professor Neurology at Aiims New Delhi.
Good morning. This session will start at 9:30 and we are exactly on time. So we invite Dr. George Villanellam to speak on anterior temporal lobectomy with amygdalohypocampectomy, the first talk.
Good morning, respected chairpersons, dear teachers and friends. We are also overwhelmed by the warm hospitality of Professor Jha, Professor Bhaskar, and the entire team at Aiims Jodhpur that we take some time to gather our words and thoughts together. I can see three types of neurosurgeons in the audience today. The first group are those who have done maybe more than 500 of this procedure and were so bored of it and asking isme abhi kya rakha hai. The second group are those who have done maybe about 15 to 20, taking their steps very cautiously but still reached a level of confidence, and that is where problems actually happen, which can take you back and totally shatter your confidence. And then I also see a few who are waiting to take the first steps, understanding the nuts and bolts of corticoamygdalohypocampectomy. Let me see if I can put forward something for each of these three groups of neurosurgeons here. So, what's the big deal about ATLH? I'd like to call it corticoamygdalohypocampectomy because that's a little more suave and sophisticated. This is the prototype of surgically remediable epilepsy surgery. It's like the Shah Rukh Khan of epilepsy surgery, where if you give the right script, it will always deliver a super hit. But if you don't give the right script, there could be problems. That is, if you select the wrong patient. And 2/3 of adult epilepsy surgery is still ATLH, and there are a variety of indications beyond typical hippocampal sclerosis, and also other surgeons like vascular and skull-based surgeons probably need to get adept with temporal lobe anatomy, because there are days when that will really stand you in good stead, even for skull-based tumors, thalamic tumors, and a lot of other things in neurosurgery. So just to put things in perspective, in this world of 7.4 billion people, though it's a surgical technique video, I have to set the stage for this. This is 10 times more common than brain tumors. So if all the neurosurgeons in India today decide to do temporal lobe epilepsy out there, I think there's enough work to keep everybody busy. But all the patients do not reach surgical care. And in India today, we have about 7.5 lakh patients waiting for temporal lobe epilepsy surgery. It's 10 times more common than brain tumors. So the spectrum of temporal lobe dissections, the commonest is the ATLAH, selective amygdalohypocampectomy, echocardiography, tailored dissections. They could be part of multilobar dissections. There's a hippocampal perspective to hemispherotomies, to posterior quadrant resections, to large other resections, and they are also gateway to other resections. So the spectrum of lesions is also very large, though the commonest is the typical hippocampal sclerosis or amygdala dysplasia. We have long-term epilepsy-associated tumors, we have cortical dysplasias, standalone type 1 dysplasias or type 2 dysplasias, we have cavernomas, we have gliotic scars. Everything possible can happen in the temporal lobe, which is a sink for epilepsy, and you could even have secondary hippocampal sclerosis. So this technique has evolved over a period of time, developed in the 50s, and the old concept was to resect more of the lateral temporal lobe, while the evolved new concept is to resect more of the medial temporal lobe. So the current standard of care, the typical ATLAH, we have 4 centimeters of resection in the dominant lobe, while we can go up to 5 to 6 in the non-dominant. The mesial resection usually typically involves the certain limits, amygdala, hippocampus, the uncus and the parahippocampal gyrus. I'll come to that in a little more detail when I go to the operative videos. So this is a very typical illustrative case, a 25-year-old female with drug-resistant complex partial seizures, already taking 3 anticonvulsants with 3 to 4 disabling seizures per day for the last 5 years. So this is the new kid on the block, an arterial spin labeling, which shows left hippocampal or medial temporal hypoperfusion and a typical mesial temporal sclerosis. So this is the video EEG which shows left temporal spikes, and interictal also we had a left temporal discharges. So almost a very typical case. We often preserve the hair in female patients. Supine position, head slightly extended with a little bit of rotation. And this is the skin flap, the temporalis exposed, the temporalis reflected. These are the typical burr holes. You can make it even smaller incision. There's still scope for refinement of this technique. And this is after the craniotomy is done. The key surgical steps, the first, we would resect the neocortex or the lateral temporal lobe. Then we dissect open the temporal horn, define the medial temporal structures, the amygdala and the hippocampus. We then go to the amygdala piecemeal excision, open the choroidal fissure, laterally disconnect the hippocampus at the base at the collateral sulcus, subpile resection of the uncus, and then finally the arm mass resection of the hippocampus. So this is how, after we open the dura, this is the left temporal lobe, this is the left frontal lobe. We've just exposed the sylvian fissure, but you can reduce sylvian fissure exposures further. We do routinely an intraoperative electrocardiography even for hippocampal sclerosis, though its utility is very limited. And we need to plan the resection limits, measure the distances from the pole, usually around 3.5-4 centimeters for a left-sided resection, and distances from the base, that is towards the feet of the patient. So this is a typical temporal neocortical resection, very simple to do. You can do it in a very refined manner, first coagulating the pia, then gradually incising into the grey matter, white matter, maintaining a small angle of resection. This schematic diagram here shows you the extent of resection, and you have a small area of arm mass neocortex resected. The next step is dissecting open the temporal horn. The usual landmark that we follow is about 3 centimeters in the superior temporal sulcus or middle temporal gyrus, 3.5 centimeters from the fold. Here you can see a gentle opening of the temporal horn, and the opening is extended further so that you damage the Mayer's loop as minimal as possible. So as lateral in the roof of the temporal horn is dissected open, then you place your Layla retractor blade very, very strategically, because that gives you an exposure of 1 or 2 centimeters more of the hippocampus, so around 3.5 limits from the head of the hippocampus, as Dr. Navneet had shown in his wonderful presentation yesterday. So this is after you open the temporal horn, zoom in the microscope here and define the structures, the head of the hippocampus, the body, the choroidal fissure with the choroid plexus seen here, and we have a depth electrode recording from the head of the hippocampus. And the next step here would be to define the limits of the amygdala. So amygdala is a large matter of grey matter substance which extends even beyond the temporal lobe. So we resect the temporal or the principal amygdala. These are the limits of our resection. The pia of the ambient cistern as we piecemeal resect. The optic tract sometimes may be seen in atrophic brains. The inferior choroidal point, which is the anteriormost part of the choroid plexus in the ventricle, and we follow an imaginary line called the Venn line. So I'll just show you in the operative video. This is how the amygdala resection goes. So once you have, that's the amygdala where the tumor holding forceps is seen. This is the grey matter here, which is seen just anteromedial to the head of the hippocampus. We resect it in a piecemeal manner. You can use either the CUSA, suction, tumor holding, a bit of everything, and gently resect it till you avoid coagulation, because there are some MCA perforators which go into the deep capsuloganglionic complex which can loop into the amygdala. Gently do it and reaching these limits. The next is opening of the choroidal fissure, a schematic diagram of what is the choroidal fissure. It's basically a potential space between the fimbria of the fornix or the hippocampus and the thalamus or mesencephalon. So this is the en masse dissection of the hippocampus. Again, a gentle traction on the specimen side, that is on the hippocampus side, shows you the choroid plexus. This is the choroid fissure being gently dissected open. Avoid coagulation. If you see a little bit of hippocampal pile vein bleeding, do not resist the urge to coagulate immediately. It will settle on its own over a period of time, or coagulate only after you see its source exactly at the point as close to the hippocampus as possible. Here you can see the head of the hippocampus being gently everted, and you can see the PCA winding around the brainstem here at the end of your dissection. These landmarks serve as lighthouses in a sea of brain parenchyma. So each of these landmarks are very important, and this is the resection limit. 3.5 to 4 centimeters practically. This is how the specimen looks like, and this is how the resection bed looks like through an arachnoid veil. And these are the structures. Sometimes you're lucky to see even the fourth nerve, the third nerve, the PCA winding around the brainstem, the basilar artery, and the hippocampus in actual Greek mythology refers to power, strength, and agility which you give to your patients when they are seizure free, and sometimes if the surgeon also feels so. And I'll quickly come to how the post-operative scan looks. These are the options for a selective amygdalohippocampectomy. I don't have time for a quick video. This is our transcortical. The principle remains the same. Enter, dissect.
George, you need to wind down.
Yeah, sure. So this is a quick video of a trans-sylvian. Again, in the interest of time, I'll go through. There's a hippocampal perspective to temporo-occipital posterior quadrant resections. So what we're actually doing is not an ATLAH, it's actually a total anchectomy, subtotal amygdalectomy, partial hippocampectomy, and partial parahippocamectomy. And there is no one size fits all, it's actually you need to modify depending on the medial extent of the lesion. So you could have lesions in all shapes and sizes in the medial temporal lobe, and 5 to 6% adverse events. How do you avoid anterior choroidal artery injury? This is a patient who had that, is by remaining subpile, avoiding blind coagulations. Using DTI for the Mayer's loop, not useful at all, and you have to identify your cases very, very accurately. And let me end with a very, very important message that a mastery of the temporal lobe is very essential, not just for epilepsy surgery, and identify key temporal lobe anatomical landmarks to make your procedure very, very safe. There is still scope for further innovation as far as refinement of this technique goes, and we need to look beyond the structural abnormality. This is not just a lesion, this is an epileptic network. Thank you very much for your patient hearing.
Thank you, George. I think we do not have much time for questions at the moment. We might take questions at the end, should the time permit. So if you could ask Ari to come to the dais and tell us about functional hemispherotomy.
Good morning. Thank the organizers for giving me this opportunity, and since this is a video session, I'm just going to show two types of hemispherotomies, and I think time is sufficient only to show the technique. I'm not going to cover the complications and all that. I think can be read who is going. So hemispherotomy, like what Dr. George said, most of the centers or most of the people who will start with temporal lobectomy, and the natural extension to a temporal lobectomy in the resective or surgery would be disconnective surgeries of hemispherotomy and PQD. I think PQD Nilesh is going to cover. So hemispherotomy, there are various types. Again, there's a long evolution starting from hemispherectomy to hemispherotomy. I'm not going to cover that. What is being done currently, there are two types of open hemispherotomies, namely the lateral perisylvian functional hemispherotomy described by Ram's group as well as from Europe. Other one is vertical parasitical hemispherotomy by Delalarde. The recent two additions are by Dr. Sarath. I'm sure he's going to talk about it in his next talk, namely the endoscopic functional hemispherotomy and robotic hemispherotomy. So if you just look at the two common open hemispherotomies that are being done, namely the lateral perisylvian versus vertical parasagittal, essentially the difference is the mode of entry into the lateral ventricle and a removal or preservation of insula, meaning disconnection or removal of the insular cortex, and either removal of temporal lobe and hippocampus versus hippocampal disconnection. All this removal happens in perisylvian technique, whereas in vertical technique, the cortical removal is even less, except for a small posterior frontal central cortex, no other cortex is removed. However, achieving the same amount of complete hemispheric cortical disconnection, leaving behind the basal ganglia and the brainstem connections intact. So the indications are for a hemispherotomy, the pathology should be hemispheric, It will be either progressive or static. The most common indications being Rasmussen's encephalitis, infantile hemiplegia, hemimegalencephaly, Spooch-Weber, or an extensive gliosis, which is more common in our country, or sometimes extensive focal cortical dysplasias also would qualify for this. What's a prerequisite for hemispherotomy is that the patient would mostly have a hemiparesis, because we are going to give a deficit in this surgery. This is something which is different from other surgery like temporal lobotomy. Just now George showed choroidal, whereas here the patient will develop hemiparesis or rather hemiplegia immediate post-op, and they usually improve to a walking level by 2 to 3 months. This should be very clearly understood by the surgeon and told to the patient and his parents, because this is something, the good amount of preparation we do for this patient and parents will actually define the outcome, because otherwise they will be disappointed at the end of surgery. Second thing is, the weakness will improve in these patients. The proximal weakness is what improves, the distal weakness will remain. That is, the finger movement and the toe movement will not come back even after surgery in most cases. So a patient who has already developed a pincer grasp and foot tap weakness would actually be a likely candidate. And whenever we are doing surgery on the left side, there's a real chance of having a language deficit unless the pathology itself has happened very early in the childhood, where the language functions have shifted to the right side. So this is a schematic diagram of various techniques of hemispherotomy put all together. We are going to look at this, the perisylvian hemispherotomy, where there are two entries, cortical windows, suprasylvian and infrasylvian. And the other one is Dellanare technique for vertical hemispherotomy, where it enters from the top and do the same amount of disconnection. So again, schematically represented. In a case of the blue lines in the same pictures, both have been shown. The blue lines indicate the lines of disconnection by a lateral perisylvian hemispherotomy, whereas the green lines indicate disconnections by a vertical perisylvian hemispherotomy, vertical parasagittal hemispherotomy. And we need to understand the anatomy. What I have realized in epilepsy surgery, whether it's temporal lobectomy or hemispherotomy, there is a change in concept of understanding anatomy. In most of our surgeries, we understand the brain as look from the top through the cortex or through the systems. We do transsylvian approach, we do intrahemispheric approach, all that. Whereas in epilepsy surgery, all the structures have to be seen through the ventricle, whether you enter a temporal horn or lateral ventricle. So going to cases. So this is a young man who had a seizure from 12 years of age and had right upper and lower limb weakness since birth following perinatal asphyxia. He had 3/5 hemiparesis. His MR showed extensive gliosis of the left hemisphere. You can see that as signal changes involving perisylvian and extensive involvement of frontal, parietal and occipital lobe, and then as well as atrophy of hippocampus, and PET also shows extensive hypermetabolism. The EEG corresponded to that, so let me go to the video directly. And Meg also showed dipoles on the same side. So this patient underwent vertical parasagittal hemispherotomy. The steps are central cortex resection, then collosotomy, anterior collosotomy, which is continued into frontobasal disconnection, then insular disconnection, which continues to temporobasal, followed by posterior collosotomy and paratoxal disconnection. So this is a video. You can see the patient underwent craniotomy. This is medial, this is lateral, this is superior, this is inferior. The arrow mark is. A small cortex is resected to enter the lateral ventricle, and once the ventricle is entered, the ventricle opening is extended anteriorly and posteriorly, sufficient to see the foramen of Monroe anteriorly and the atrium trigone region posteriorly, like this. This much anteroposterior extension of the cortical incision required. Then we start doing the collosotomy. Here the corpus callosum is cut from inside out through the ventricle, so that we enter the region of the cingulate gyrus, just below the cingulate gyrus. The landmark here is the DACA, and we see the artery, and then continue it down to the base. Then we do the basal disconnection, where I usually make a cut along the inferior caudal gyrus, take it to the ACF base, and preserve the pia. In all hemispherotomies, the brain parenchyma is removed, vessels are not coagulated, pia is not open as much as possible. So all along the ACF base, the pia is preserved, and this horizontal cut from lateral to medial is brought and joined to the posterior anterior cut from the anterior colostomy. You can see the olfactory behind the pia. This is the DACA turning on the genu, ACA turning on the genu, and then all along the pia is. This is the ACA on the genu. Next is go and do the insular disconnection. Here the landmark is choroid plexus entering the temporal horn at the atrium, and then the disconnection happens lateral to the choroid plexus all along this. Here you don't see the anatomy. The cut goes medial to the insular cortex, lateral to the thalamus and the basal ganglia. So again, navigation can be used, but accuracy may not be that good. Again, anatomy is more important here than navigation. The incision starts from posterior anterior. You will find small vessels, perforator vessels going through here from insular cortex. The ciliary fissure is lateral to us, so you don't have to worry about the MCA. The cut goes all along, opening the roof of the temporal horn. The anatomical landmark is roof of temporal horn. We cut from posterior to anterior, and the whole temporal horn is opened up to the all up to the temporal horn, anterior fold of the temporal horn, and then this frontal cut is connected to the temporal cut to make a temporobasal disconnection. And then here the amygdala is removed, and you actually can just disconnect the hippocampus and leave. But I always prefer to remove the hippocampus because it's there and more comfortable removing that, gives me more confidence, control. So the hippocampus is again removed, the same technique what George showed, and subpially the pia over the hippocampal sulcus is peeled off. I do not coagulate them, and then the hippocampus is rotated, and body tail is cut. Then hippocampus is removed. So this completes the temporobasal disconnection. The frontobasal disconnection over the ciliary fissure is connected to the temporobasal disconnection here, so that the lateral disconnection is complete. Then goes to the last part, namely the parieto-occipital disconnection, which is continuation of the posterior colostomy down, and then this disconnection goes and joins the end of the choroid fissure at the level of the atrium. So you can see here again the pia is preserved, and this is where usually the quadrigeminal system comes medially. We just preserve the pia all along and join the posterior colostomy to the medial point. So that completes the surgery. So this is a post-op scan. The immediate post-op, this is how it looks. There is disconnections along this, and then there is a follow-up scan at 3 months, which shows there is a porencephaly which has developed, and this patient is seizure-free for last. This patient is 5 months. Another case, 8-year-old child. I'm not going to show the video in this case. Seizures since 1.5 years. This was a Rasmussen encephalitis initially observed. You can see the evolution of the atrophy. This is a scan done in 2021, which showed minimal atrophy, and over a period of 1 year, the atrophy has progressed significantly on the right side. You can see so much atrophy on the right side. And this patient developed motor weakness over a period of one year. He had diffuse hypermetabolism, MEG concordant. Technique will be the same, except that we do the surgery from lateral instead of superior. In the addition is anterior temporal lobectomy and hippocampectomy. Yes, I'm finishing. And these are just pictures. Temporal lobectomy, opening the frontal horn, then same technique, corpus callosatomy from lateral, and completing the temporal lobectomy. And this is a complete and frontobasal disconnection. Then the posterior disconnection, both lateral and medial disconnection. This is scanned in 6 months later, and this is a follow-up scan at 1 year. This is the amount of motor or improvement after, in spite of, for a complete disconnection.
Ari, can you
patient
please
has
stop?
the last slide.
You will miss your flight.
No, thank you. So I just wanted to show this only. Even with the complete disconnection, patients at follow-up will have this amount of quality of life. They'll have the distal weakness. Other than that, they'll be able to walk and carry out their daily activities. Thank you.
Thanks, Hari. We now invite Dr. Nilesh to speak on posterior quadrant disconnection.
Nilesh, can you try and cover up on the time?
Sure, sir. So, good morning again. I'm covering the posterior quadrant disconnection. This procedure is primarily performed for most of the common indications are dysplasia, gliosis and porencephaly, and oliguria. Again, whenever it is a full volume pathology, it is a kind of difficult surgery. If it is a gliosis and porencephaly, it is very easy surgery. Just steps to cover: position, incision, craniotomy, disconnection line, and what can go wrong and where. Normally, I put a supine position with head in complete lateral position, because at the same time you have to resect the amygdala, and at the same time you have to go to cingulate. So generally, you have to move the microscope from one end to the other end, so having a complete transverse position helps. Generally, even if you get a little inclination anteriorly, taking out amygdala becomes really difficult. And you have to excise amygdala completely, that is the key. That is my general incision. Most of the so the incision line generally follows the brain disconnection line, and my incision crosses the midline by maybe a centimeter or so. This is generally a craniotomy. I normally put my burr holes on the midline, just paramedian, maybe around a centimeter. Initially, I used to go to the midline and expose completely the pars marginalis and the postcentral sulcus, but nowadays I generally don't do it. I put 1 centimeter paramedian. And this is my craniotomy. These are the cuts, what we go for a posterior quadrant disconnection. And most importantly, I would like to tell this. We completely put this superior temporal gyrus till temporal pole, and this cut is most important because that talks about the parietal opercula. And this cut just goes posterior to the sensory gyrus or postcentral gyrus. It's again the same thing, but explained from a medial perspective. So if you top perspective, if you look at this, this is a central sulcus, this is a postcentral gyrus, and this is a pars marginalis. So your cut, generally the cortex is cut on the top or on the crown of the postcentral gyrus here, so that once you resect this cortex, you should see the pars marginalis. Pars marginalis is nothing but a superior end of a cingulate sulcus. Most of the indication of this kind of cases is for oliguria in my series, and that's why in majority of the bilateral parieto-occipital gliosis or oliguria, the epileptogenesis lies in the parietal lobe. And most of the time, if we, for the fear of this anatomy, if we extend this cut here somewhere, just to stay on a safer side, you will have a recurrence. At the same time, you will have a recurrence here if you don't extend this parietal opercula. Majority of my failures are coming from these two regions. And the third region is medially, which I will be covering later on. So that is how again the disconnection line goes on. We cut the cortex of the gyrus, and we go into the white matter and keep cutting till the time we get the ventricle. Now, step by step on this side, so this is how you go, and this is how you cut. So if you look at it, this is your central sulcus, which is coming down, and this is your postcentral gyrus, postcentral sulcus. So you have to make sure that you see this postcentral sulcus till depth to achieve the complete posterior quadrant disconnection. Because again, the parietal lobe is a major culprit in epileptogenesis, and for the fear, if you go leave even one gyrus or two gyri here, then you will invite a recurrence. So that is how it goes. Now if you look at here, this is a central sulcus and this is a hand knob. So your disconnection line should come till here, and you should see this, you should remove this cortex and see the depth of the sulcus here, and you should see the insula down there once you resect the cortex. So that is how your disconnection line goes in the posterior quadrant. Again, this is the medial part. So once you resect this cortex,
you see the pars marginalis and a cingulate sulcus. So once you come down, most of the time here, the patient, because of the patient positioning and our understanding of the anatomy and position, it is generally distorted, and you will end up taking this line directly to the corpus callosum. And most of the time you will leave this part here. That is the precuneal area. Again, this is the site of recurrence in most of, in my own experience and series, this is the site of recurrence. So that is how the cut goes. So generally what can go wrong and where? So generally from my failures, what I learned is if you leave the cortex here, you will end up having a recurrence. You will keep the residual. Secondly, while disconnecting this part, either you will end up leaving this part here and your disconnection line goes like this, and you will have some cortex left here. And secondly, if you put a retractor, your retractor, because you might have to put a retractor here, your retractor may slip to the thalamus and you may invite a hemiparesis. Secondly, if you go to this part, your internal capsule is touching here somewhere. So if you are not careful, when you are approaching from the up to the insula, you may end up in a white matter. You generally lose the sense of white matter and gray matter, the direction, and you may end up in the posterior part of the insular capsule. So these are the potential points where you can end up having a deficits. Many of these patients, if you go very close, will have a hemiparesis or partial deficits in the first post-op period because of the retraction edema. But generally that settles. But if you slip your retractor here, you will end up with a permanent damage and deficit. Another thing is the amygdala resection. In these cases, amygdala, if you are tackling the cortical malformation or dysplasia, amygdala has to be resected completely. If you are talking about you are operating for a oliguria, you may get away without resecting the complete amygdala. This is how the disconnection lines goes through. Thank you very much.
Fantastic. Thank you for sticking to time. We call upon Sarat to present his paper, Innovations in Epilepsy Surgery. Sarat around? Yeah.
Thanks, Milind. I was hurriedly deleting as many slides as possible because I know
you already lost 1 minute of your time.
Are you counting this also? Yeah, we are long-standing friends. Have some pity on me. So I'll definitely wrap up as early as possible. So this is our team. I would like to particularly acknowledge Manjari and Dr. Ramesh for sitting here, and of course Mohit is one of our ex-fellows. We are very proud of him this year. So we all know that there are few very important, landmark studies, innovations. I'd like to mention some of them. some of my own humble contributions. So we are all aware about the WEEP study. It has more than 1,000 citations. And this was a landmark paper which we published, now has more than 500 citations. And this for the first time showed that not only kids do become seizure-free when you operate them early, but it's also important to preserve their cognitive status. And that's the reason they have to be operated as early as possible. And since procedures like hemispherotomy is done at ages like 4 or 5 years, where the blood loss and hypothermia are complications which are very, very massive, clear and present dangers. That is why we need to develop minimally invasive strategies. So these are the few of the innovations on which I will be talking. First is imaging. We have already discussed about the silent revolution of imaging in epilepsy surgery. As epilepsy surgeons, we have become much more sensitive on picking up these subtle images, which we used to think are earlier innocuous, but now we understand the significance of the same. For instance, this is a patient who had undergone 12 MRIs outside, and finally following a CG, only then we were able to pick up this basal subtle cortical dysplasia, which was histopathologically positive, and following surgery, the patient became seizure-free. And hence, it's a big leap forward for us only to understand that we can pick up these lesions more confidently on MR imaging. So I think that has been the biggest innovation, becoming more sensitive about the subtle lesions on MRI. The second is functional MRI. We cannot do without doing a functional MRIs, and we have developed all paradigms for functional MRIs, and we have published multiple papers. That's been the workhorse for workup of all the patients in our center. MEG we have done more than 2,400 cases, but we were fortunate enough to have senior research fellows and research associates who went ahead to develop more advanced paradigms, like this video spread of the networks, as well as presence of coherence studies, which allowed us to actually analyze MEG more effectively. And these are some of our publications from MEG. And this paper, for us, it's been very, very important, where we showed for the first time the concordance between ictal SPECT and PET, not MRI. And using this paradigm, we were able to at least tackle the temporal pathologies, which are MRI negative, but concordant on PET and ictal SPECT because they have good outcomes. Now, multimodal imaging is something we started way back in 2015, and these are the papers which are published from UCLA, where I did my postdoc fellows. And from then onwards, there have been many papers which have come up. And as it can be seen that once we do multimodal imaging, the pickup of networks becomes progressively much better. And as you can see, multimodal imaging provide a vantage point, and that has led to development of post-processing, which I think is mandatory for all the institutions. Electrocardiography. Almost 2 decades ago, when we started electrocardiography, this was something which was looked down upon from the major centers in US. They thought it's not very effective. But fortunately, in UCLA, they considered electrocardiography to be very important. And from that perspective, we were very fortunate in our center because we've garnished a huge experience on electrocardiography, published multiple papers, more than 2,500 cases. And as you can see, we have the scoring system by which we are able to quantitate the electrocardiographic recordings which come on. It's become a workhorse for us now. Stereoencephalography. A lot has been told about it already. I won't speak much about it. But I think we are in the process of developing a limited electrode SCG. Even though when I present these papers on an international forum, there's a lot of criticisms. They say, how can you do it? But it's been more favorably accepted in the Asian Epilepsy Surgery Congresses, where we deal with similar, and in the AOAC Congress. And definitely we have found that SCG is amazing because thin electrodes can be easily explanted, and we do a triad of recording, stimulation and ablation. And these are the parameters we usually follow. We use an O-arm as well as a ROSA. We record the spontaneous seizures. We stimulate to produce a habitual seizures. And these are a couple of videos of spontaneous as well as habitual seizures. And you can see they're absolutely the same, which strengthens the hypothesis. And then finally, we do an electrocardiographic based excision following thermocoagulation. We usually, by doing thermocoagulation, it's not that we achieve cure in all the patients. It's only in 20% of the patients that you can achieve a cure, but it becomes a diagnostic element in order to validate the hypothesis. So this is an example, completely MRI negative pathology, but PET and SPECT showing temporal localization. We put in something like 13 SCG electrodes, and we were able to resect the amygdala and temporal lobectomy and spare the hippocampus on the left side, and the histopathology was type 1 FCD. So in our setup, using a standard of around 7 electrodes plus or minus 2, we've been able to achieve an outcome of 70% for temporal and 53% for extratemporal pathologies. And 90% of our pathologies have been MRI negative. So, and this correlates excellently with, in fact, is better than most of the other international studies. But of course, we have done only about 400 electrode implantations. We need to get more experience on this. Now, the other revolution, we find that we have switched over to complete temporal lobectomy, and this is based on 3 cardinal studies. One is by Josephson et al., a very beautiful meta-analysis where they have shown that a temporal lobectomy is much more better than selective. A study by the UCLA group where they have shown that the cognitive difference is negligible whether you do a selective or a temporal lobectomy. And our own publication in Nature, where we have been for the first time able to demonstrate that networks in hippocampal sclerosis are stronger in extratemporal regions rather than in temporal regions. And based on these 3 evidence, we have stopped doing selective amygdalohypocampectomies. In minimally invasive strategies, these are the techniques which we developed: endoscopic, robotic radiofrequency disconnection of hypothalamic hematoma, endoscopic hemispherotomy, and corpus callosotomies. In hypothalamic hematomas, we have developed a robotic technique, and Dr. Ramesh has been fundamental here. This was an endoscopic technique done long time back, and after me discussing with Professor Kamiyama and Dr. Shirozu, we developed this radio frequency by which you can see that you can put multiple trajectories, and you can actually cover every aspect of hypothalamic hematoma, unlike the laser where you can put only one electrode. And similarly, SCG guided thermocoagulation, again, which has limited access to hypothalamic hematomas. So this is how we do using the OARM and the robotic system. Few examples, and we've been able to achieve about 80% good outcomes, even though 20% of our patients had to undergo repeat surgery. But the repeat surgery again is a very straightforward procedure. As can be seen in the study, hypothalamic hematomas have had the best outcome. 1 minute more. Okay. Hemispheric disconnection. So we published the first paper of hemispherotomy from India, and then we developed the endoscopic technique again for the first time. And these are some of our papers which we published through a small route, and now it's in the textbook of Pete Engel's textbook of epilepsy, comprehensive textbook, which will be coming in the recent. There's few examples. You can see this child operated in Malaysia, having 200 seizures, lost only 40 cc of blood. It's a patient endoscopic again, which I did with Ari Vazagan during the 2022 Stereocon conference at NIMHANS. Again, patient I believe is completely seizure free. So we have validated hemispherotomy and showed definitely the better outcomes with hemispherotomies. And it is also very effective for redo open hemispherotomies. This is a case which was operated during Ginde's oration, came back to me with recurrence, and I did a redo endoscopic, and patient was completely seizure free. Developed endoscopic corpus callosotomy, and this is the latest innovation where we have switched all our hemispherotomies to a bloodless technique, which is called as robotic thermocoagulate hemispherotomy, and this came out in the cover page of JNS. So this is how we do it. We put at least 15 to 16 trajectories and about 100 burns, 100 to 120 burns. And you can see this beautiful disconnection here, and again another beautiful disconnection here, and patients seizure free. Another patient at 1 year follow-up. Few more patients. Again, you can see this beautiful disconnection. So this we have done in about 20 cases and has become the workhorse for all hemispheric disconnections, because we do not lose even one drop of blood. It is a truly bloodless surgery. The only issue is it takes a long time. It takes 7, 8, 9 hours. But then my colleagues like Ramesh have become experts. He can now do it very, very fast along with my fellows. And as you can see, the recovery is amazing. There is hardly any post-operative fever, unlike even endoscopic where the fevers may continue for 4 or 5 days. And the recovery is also very good. And it seems to be a really promising technique, at least in our center. It's become the workhorse for all hemispheric disconnections. For me personally, it has been a great sense of satisfaction because I have seen an era where you used to produce a hole in the brain. For kids who are 3 years, 4 years, they can hardly, that's an age when you need to do minimally invasive strategies. And I think it's been very satisfaction because we evolved to a surgical procedure which just produces a line in the brain. And yeah, I'm finished. So these are our other innovations: radiofrequency corpus callosal ablation, and of course on the paper on TPO disconnection we have published a series for bilateral parieto-occipital gliosis, and that again is the first series from the literature, where we have shown that in bilateral parieto-occipital perinatal related gliosis, doing a TPO disconnection seems to be very effective. So imaging, there is a silent revolution. ECOG has become a workhorse even in SCEGs for us. SCEG has become the sole invasive technique for us. SCEG guided thermocoagulation again has become the workhorse. We do a triad of spontaneous recording, production of seizures, production of stimulation with habitual seizures, followed by thermocoagulation. And hypothalamic hematoma, again, the workhorse is robotic thermofrequency ablation. And for hemispherotomies, we have switched over from endoscopic to Roche. So it's important for us to push such techniques into mediums where we can interact with policymakers. And this is one such congress, Neurosciences 20 with G20. And for those of you who are interested, please get in touch with me. And it is going to be held just one day before the Leadership's Congress. Thank you very much.
Thank you, Sarath. We'll take any questions later on if time permits. Could we ask Dr. Krishna Kumar? Krishna Kumar is going to tell us about functional neurosurgery overlay, epilepsy mimics, and strategy to manage them.
A very good morning to all of you, and seeing the seniors sitting here. I think this talk is basically fundamentally for those who start their practice in functional neurosurgery, and there are so many mimics which come into play, where in institutes we have a separate movement disorder division, we have a pain and palliation division, gamma knife will be done by one expert, whereas the epilepsy surgery will be done by another team. So there will be some functional interlay or cases which mimic both the parameters, where the functional neurosurgeon will have to take a call on it. And there are some cases where the epileptologist will hand it over to the movement disorder team and vice versa. So let me start with a similar case which we had, an autistic child who had involuntary movements, and he had typical hand flapping movements, but the problem was that these were episodic, and to the layperson as well as the physician near his residence, anything which happens intermittently is seizure. Anything which is persisting is some kind of genetic disorder. This is the basic fundamentals which they work on. But this boy was relatively symptom-free for some time, and it is totally disappears during sleep. So when he gets emotional, he gets all this tantrums. So hyperactivity and restlessness and anger outbursts. So he was evaluated outside in 2 centers, and they were referred to us Cori complex partial seizures, kindly evaluate. So when this is how the involuntary movements used to occur for him, as well as the verbal outbursts, and you can see the involuntary movements of the hands, attitude. So definitely we were encountering something like a chameleon, a borderland case, or is it an epilepsy mimic? But to a center which deals with most of the referral cases, this was not a difficult diagnosis to make. You can see the spectrum is quite, and you can see the epileptic seizures and their differential diagnosis. Come across several conditions where when generalized convulsions have been mistaken for chorea or vice versa. You have less paroxysmal events during sleep like restless leg syndrome and focal symptoms. There can be movement disorders which mimic seizures in the form of focal syndromes, and of course tics like this, the child which I showed in the video. And as the age of the child advances, he becomes an adult or a near adult. You can see several of these functional neurosurgical overlay happens with each one having a particular diagnostic catch which the initial evaluating physician can miss because that event did not occur in his clinic. So one should always be borne in mind. And of course, need not elaborate on tics. Most of us must have treated it, the surgical armamentarium at least a couple of times. And the motor stereotypies are another pattern which will mimic seizures. And unlike tics, they can be a fixed pattern and simple motor stereotypies, only leg shaking, only thumb sucking, only teeth clenching. So such kind of versus a complex stereotype. And this is another area which almost mimics an epileptic fit. It's rare, but the PKD is definitely a diagnostic challenge. And there are identified criteria for PKD. So, and typically it responds to carbamazepine to an extent, but it is of something which is of interest to the movement disorder physician or movement disorders. So this was I think we have seen up to the movie interval. Let us go to, so this boy underwent deep brain stimulation. He had bilateral CPI implantations done, and this is his top visit. He is relatively symptom-free. This is another referral which came to us. This was also paroxysmal. This child had near normal intervals during her early age, and as the age advanced, she had severe dystonias. And by the time she reached our center, she was almost like a full-blown paroxysmal dystonic syndrome. And she was DY-2 negative, and this is her status after the bilateral GPI EBS, and this is the post-op, 3-year post-op. She is almost symptom. So this was another patient who had an epileptic mimic and responded very well. And was one of the Aicardi-Gotti syndrome which we manage surgically. And another, this was a typical DY-1 dystonia. In his initial ages when he was working as a clerk, his colleagues used to call him epileptic because he used to fall down and he cannot execute most of his functions. And being a DY-1 dystonia, underwent bilateral. So to conclude, there is a lot of discussions which can happen in the functional neurosurgery overlay with epileptic mimics. It throws up a lot of diagnostic and management strategies. For the surgeon, it is mostly centered around the GPID.
Thanks, KK. Questions at the end. We have great pleasure in inviting the host, Dr. Bhaskar, to speak about the epilepsy surgery program at the host institution, Aiims Jodhpur.
Maybe I can start off by thanking Mohit for giving me the opportunity, or rather forcing me to present. You might feel offended otherwise. Yeah. So it's the last talk, I'll just wrap it up fast. So I think we all know very well over the last 1.5 days, it's a team. The surgeons take all the credit, but then finally it's the team which finally determines the outcome and what happens eventually. And like the saying here, somebody had to make a start for wherever we are planning to reach. So we've got this opportunity here for starting the journey at our institute. So these are all the people. I am sure not all are in this slide. So who have contributed to what we have been able to make a small start to our epilepsy surgery program per se. So at our institute, neurosurgery, neurology, we joined in 2017. The rest of the departments were there even before us. Nuclear medicine joined late and their equipment arrived a bit later. We are lucky enough to even have a pediatric neurology join subsequently. And in starting this program, what is very important is the institution and the department's visions should match. And we were also extremely lucky to have our director who supported us to the hilt. And that's one main reason why we have been able to at least make a start. And the Mentor Institute, I would like to place on record a sincere thanks to Matthews and George, who helped us in the initial surgeries and subsequently also when in doubt, we always consult. So these are all the departments that contribute and finally make a program work. And in this, a special mention to, you have already heard our radiologist, Sarvesh. He's a small man, but packs a big punch and heavily dependent on him. And as ma'am had pointed out, he does spend a lot of time in evaluating the scans, and then when we tell him no, something is being missed, he spends more time again and comes up with some idea or the other. So epilepsy board, we do have it once in a month. We discuss, debate, and many a times agree and many a times don't agree on what we agree, and then we make a plan, and then either we cancel a plan and it goes on till we are all very much sure that what we are planning to do is what's going to work best for the patient. Just a few tips about what went through my mind about epilepsy surgery, what to do. So subsequently Mohit had joined, so he was lucky enough to be a trained epilepsy surgeon from one of the best centers in the country. So for me, I had a bit of experience in neurosurgery. I was trained at Chitra, so I had seen a bit of epilepsy surgery, but then after that, years of hiatus of not seeing, not doing, and no formal training. So what do? No options, learn, go back to the drawing board and start all over again, read, see videos, and then manage. And do find a mentor. It comes in handy in the beginning and later on also. So what did I do? Have a realistic goal. As neurosurgeons, epilepsy surgery was something which was slightly not in the routine syllabus. We all saw it used to happen lots of places, but we were not actually, I was at least not actually in touch with what to do and how to do about it. So get educated, because you will have to counsel the parents, the relatives, the patients about what is your goal, what is their goal, and how do you reach a common meeting point. You do have to read about the stuff which you are seeing in the earlier presentations, otherwise it all goes over the head. What I told myself is when you see videos, especially from senior people, you always get fascinated and you say, yeah, this is what I am going to do tomorrow. It doesn't work that way. They might have been able to do it, you might not be able to, but that's fine. You have to make a start somewhere. So like Mohit had presented yesterday in our department, we routinely use the VRT even in epilepsy surgeries and it works. You will gradually get around to using the CT, the MR and the VRT images in your head so that when you operate, you actually know what you are doing, where you are going to encounter which structure and how do you do it. And for a starter, I stick to the plan strictly, no deviations, and for the time being it works. And what should one be careful about? Not assume that we have done temporal lobectomies for other indications, Sylvian Fisher dissection for other indications, and that's enough and you can manage. It does help if you have that skill and knowledge, but you will have to tweak it a little bit to fit into the epilepsy surgery goal. You will have to become a little more aware about anti-epileptics, about the anesthesia protocol, get in sync with them, how are they going. And when I have a doubt, there's always the internet to go to, there's always Mohit to consult to and the mentors. So it has helped and I've been lucky. So here, what I've been able to do now is, we've done around 33 cases so far, 2 redos. So the way we started was in 2019 November. Initially we managed to kickstart in a nice manner, did 9. Then the first wave of pandemic hit, and once that hit, leave epilepsy surgery, we didn't have even basic neurosurgery ward elective cases. It was all emergency and COVID and nothing else. So the program came to a grinding halt. Then again kick-started. After the first case, the second wave, again shut shop. Then the third, and now we are again back and we are going along smoothly, and hopefully it will only get better with time. So it's a small number. I will not go too much about our results, but we've operated the extremes of age. The Engel score, it's too small a number and spread over almost 3-4 years. But because of our case selection and we have been very strict, we have not as of now started doing any of these doubtful ones. So that's why the outcome so far has been very good. These are a few problems that we encountered along the way. Patients not able to buy anti-epileptic drugs due to the pandemic. We inadvertently gave a full dose anti-epileptic drug in the pre-op itself. One patient did have hydrocephalus in the 3 months MRI, but was not symptomatic for it. Quadrantinopia, I have my own suspicion, even though all the patients were not cooperative for a pre and post. Being in the initial phases, my hunch is most of them would have a quadrantinopia, and I do counsel them upfront. And the patient background that we get, I don't think quadrantinopia is a major problem for them. The seizures and the trouble is what it is. Technical issues, it does happen. You place the ECOG, it doesn't work. The electrodes are faulty, so those are things that, and the indications have been the routine so far that we have encountered. So just a few illustrative cases. This boy had a left parietal ganglioglioma, operated, excised, 3 months, was doing well. Then he had a seizures again, re-imaged. Savesh had managed to localize a small 2 by 3 millimeter residual, and we reoperated. Thought we'll use the navigation to localize, but unfortunately the navigation localized, but as soon as we opened the dura, the cyst got drained and the navigation was pointing somewhere here, the lesion was here. So based on what we had discussed in the epilepsy meet, we knew that this is where the cyst cavity that we had to go and remove it. That was removed and the child has done well subsequently. Routine case, went chasing after the tail, and then subsequently the patient had an immediate post-op hemiplegia, thankfully recovered completely in 3 months. A lesson for me to learn. The 4-year-old girl, polymicrogyria, underwent an hemispherotomy. Here I did manage as many videos as I could, including Dr. Sarat's endoscopy one, and then I realized it's best to do it in a conventional manner. Did very well. Immediate post-op onwards, she became seizure-free, hemiplegic. That is recovering. The only issue was she did develop symptoms of raised ICP, for which she was definitely symptomatic, but thankfully recovered with just decongestants uneventfully. So he had a DNET in the left temporal lobe. So we excised the DNET. We did mapping from the hippocampus. There was no spikes, so we decided not to do anything further. 6 months he did well, then had a cluster of seizures, re-imaged, and here we did have a lot of debate and discussion in the epilepsy board meet. The hippocampus, which earlier was looking kind of normal, which we don't know whether it was due to the existence of the lesion or otherwise, it had changed in nature on the imaging, so we reoperated, did an amygdalo-hippocampectomy, and he is doing well. So moving forward, the epilepsy monitoring unit is being set up and hopefully in a month or so will be functional. We are looking forward to these as and when we are able to procure, and hopefully we'll be able to put them to use. And finally, thank you all for making it here and hope you all have a pleasant stay, academic and otherwise also. Thank you.
Thanks, Bhaskar. Congratulations for establishing a good program here. Now there are more than 60 epilepsy surgery centers in India. All of them, almost all of them, started like this only. I'm sure your program will expand and improve with new infrastructure and your continued interest. Best wishes.
Thank you.
Now, please give us some time for discussion. How much time we can take?
If I say a couple of minutes, that will sound very offensive.
Well, I have to tell Bhaskar, you will miss your flight as well. So I need to remind you about this.
Yes, sir, this Bhaskar, he will be here in Jodhpur, so I don't have to bother about flights.
All of you decide.
I'll leave it to the host. Finish?
Maybe, okay, let's make it a quick 5 minutes.
My flight is after your flight.
Just three quick questions from my side. First is to Nilesh. Nilesh has left. Nilesh is in airport. So, Sarath, Sarath, you're doing very good work. There's an impression that people in institutions can do this sort of innovative work. What is your advice to a lot of young people in the audience without any institutional support and background? What way they can do all this work? And KK, third question, please prepare the answer. KK, where are you? See, like Milind and you have dual interest in PD and epilepsy. Is that the reason why you are able to pick up mimics more? For example, me, Sarath, Nilesh, we are doing only one area. So just answer that at the end. Sarath, please.
So, one of the dangers of making a 10-minute talk is that it may sound, very inspiring for the young people to take up, but it kind of totally erases all the hard work, all the disappointments, all the failures which you have. So when you stand up on the podium, people are only able to see the front of you, they don't see the knives which are stabbed at the back. So that's from a quote from a cartoon. So all these innovations, they look good. And when we present it, it looks even more better. You write a paper, it looks very satisfying. But when you need to start something, you have to again go back to a very, very fundamental and a ground level. So you can see one of the papers which we published, it's very highly cited, on epilepsy surgery guidelines for India. So when you start an epilepsy surgery program, most important is to have the neurologist on your side.
by whatever methods, do it by crooked or by marriage or whatever. But thing is, you need to have the neurologist on your side, and then the radiologist. You again need to have the radiologist on your side, because many radiologists feel that imaging is, very, it's very easy. It is not. Epilepsy imaging is one of the most toughest imaging in neurology, and they need to get that experience to do it. Any center will have an 1.5 Tesla MRI, so that is okay. You can double back up an electrocorticography with video EEG, that is also fine. You start with hippocampal sclerosis, be aware of the red flags. So when you operate a hippocampal sclerosis, be aware that, let us say, if you're doing a right-sided hippocampal sclerosis, if the verbal memory is not good, again be careful. If the patient is having semiology, so you should be aware of all the red flags even when you start with hippocampal sclerosis. But then you can start with the type 2B cortical dysplasias, which look very good. Then if you have a post-infarct seizure with large porencephaly, you could also do a hemispherotomy. So be very, very careful in choosing the cases and creating a very good platform. And finally, last but the least, it's very important to do public awareness programs. So that when you do it, let the public be aware that this program has started there. So from that perspective, Nilesh is not here, but he's been able to create a visibility. He was a fellow on our side, but he created a visibility. He said Bajaj Alliance Epilepsy Center. So there was a marker, there was a visibility, now people started going to him. Now if somebody says that I am in Department of Neurosurgery, I also do epilepsy, people may not get so much attracted to it. So this would be my advice to anyone who starts epilepsy surgery, and I strongly recommend anyone to doing this to also take up a fellowship program. So we have a fellowship program in Aiims now open for 2 years. It's not very competitive. The questions are very straightforward. You could do it and you could have an amazing experience for 2 years. We are doing on 2 to 3 cases a week right now. We have so if you do a fellowship for 2 years, you will just come to see every kind of case possible, and you will have that confidence to start this.
Thank you, Krishna.
The answer to your question will be in 2 parts. One is the background in which the juniors are now getting trained, and the power of the industry to drive them to some kind of surgeries which will involve the implants, which are costly. So we see a lot of overlay in our center where the referrals come all over the country, and we see a definite subset which have any involuntary movement which is which occurs periodically is epileptic seizures to many. So that kind of awareness should reach the junior most level. That is why we propose that we would present such a paper, and we picked up some cases from our institute which were involuntary movements which were present only periodically. So this functional overlay could be highlighted. It was only to highlight that such a fact.
Thank you. No, I think I'll take the chair's prerogative and stop the session here. Hand it over to Mohit. Yeah.
So, thank you everyone. I would just like to say we come to an end to the stereotactic and functional neurosurgery CME at Aiims Jodhpur. So more than 60 years have passed since the inception of stereotactic and functional neurosurgery in India, but this field of neurosurgery has still not reached every part of the country. This is the first time that such a conference has been organized in the state of Rajasthan. So I would like to sincerely express my gratitude to the Issfn, Professor Aditya Gupta, Professor Milind Sankhe, Professor Dwarkanath, and Professor Ari, and the executive committee for providing a much needed boost to this subspecialty in Rajasthan. I would now like to invite Professor Aditya Gupta, President Issfn, to the stage, along with Professor Dwarkanath, Secretary Issfn, to present the awards. I would also like to call upon organizing presidents Dr. Deepak Jha and Dr. Bhaskar. I would also like to call upon the co-organizing secretary, Dr. Sucharita, to the stage. So we would like to start with the awards for the paper presentation. The first prize in paper presentation goes to Dr. Aiims Gupta from Aiims Jodhpur. I would like to invite him to the stage to receive his award from Professor Aditya Gupta. First prize in paper presentation. The second prize in award paper category goes to Dr. Nihal Ahmed from Aiims Delhi. I would ask him to receive his prize from Dwarkanath. The first prize in poster presentation goes to Dr. Pooja Salunke from Hinduja Hospital. I would ask, is Dr. Pooja here? Yeah. Congratulations, Dr. Pooja, for receiving the first prize in the poster presentation category. The second prize in the poster presentation goes to Dr. Jogender from PGI Chandigarh. I don't think he is here. We'll just hand over to one of the PGI faculty, Dr. Navneet or Dr. Sushant. Thank you so much. I would like to thank all the eminent national faculty who took out time from their busy schedules who came to Jodhpur to provide a comprehensive overview of the subspecialty. And I would like to thank the Aiims Jodhpur administration. I would like to invite Professor Aditya Gupta.
So I think it's been wonderful, actually, 1.5 days of very nice academic content. And I think on behalf of the ISSFN, I would like to place on record my thanks to Aiims Jodhpur for a very, very well conducted ISSFN CME. Absolutely in line with the ethos of a CME, which is supposed to be a very basic level, very well-conducted educational activity for stereotactic and functional neurosurgery. Specifically, Dr. Deepak, Dr. Bhaskar, Dr. Mayank, Mohit, and some of the residents, of course, who have played a key role in the helping out in the conduct of this meeting, especially, I think I would say Ayush, who has been always available for any issues. And of course, all the supporting staff, organizers, sponsors. So I would like to place on record my thanks from the society for a very, very well conducted meeting. Also, I would like to invite all of you for the next year's meeting, not only as the president of the ISSFN, but also as the organizer for the next meeting in 2024, which will be held in the Delhi NCR or now. We'll shortly let you know the dates and the venue. So again, thanks very much for a very, very well conducted and organized meeting.
Would just like to thank everyone involved with this conference. First of all, I would like to thank the national faculty who took out time from the busy schedules to grace this conference and provide us a comprehensive overview of this specialty. I would like to thank the Aiims Jodhpur administration led by our Executive Director, Professor Madhavanda Kar, Deputy Director, Mr. Manu Manish Gupta, and Professor Kuldeep Singh, Dean Academics, Professor M.K. Garg, Medical Superintendent, who have always supported our department in all our endeavors. I would like to thank the patients who agreed to be treated during the operative and the Botox workshops, and the delegates who participated in the conference to make it a success. Both the patients operated yesterday are doing fine. Both have got their post-op CT scan done. Both are doing perfectly well. I would like to thank Dean Examinations, Professor Abhinav Dixit, and the personnel looking after the examination hall for arranging the venue for the Botox workshop, which was a big success, for which Dr. Sucharita Anand needs to be thanked. My co-organizing secretary for putting together the star attraction of the conference. I would like to thank the entire departments of neurosurgery, neurology, radiology, anesthesia and pathology, all the faculty, Professor Jha, Professor Bhaskar, Dr. Samita, Dr. Mayangar, the treasurer who has been working day and night to ensure a successful conference, residents, especially Jigish, Pankaj, Shama, Ayush, Ishan and Apurva, who were there interacting with all the delegates and making sure everything goes perfectly, the nursing officers, OT technicians and the support staff, Srinivas, Ashwini and Shekhar, who have been working for the past 1 month. Organizing a conference is always a team effort. And I would like to thank the auditorium staff led by Mr. Harshit Bhandari, Mr. Rakesh from audiovisual, Mr. Shiva for photo and videography and the housekeeping staff. I would like to thank Mr. Thakur for the food and catering, Mr. Mahinder for arranging the transport, Mr. Gajendra for the guest house, and Mr. Sachin Vyas for the internet, and Mr. Nitesh from Shreya Enterprises for organizing the bookings for the dinner venues. And finally, I would like to thank our business partners, without whose support this conference would not have been possible at all. Sun Pharma, Intas Pharmaceuticals, Johnson & Johnson, Medtronics, Arc Surgicals, Indian Surgical Solutions, Schiller, Ascolab, Allergan Healthcare, DSS Image Tech Private Limited, Baxter, Rajaram, Microlab, Surgiware, Dr. Reddy's Lab, Icon Life Sciences, Carl Stores, Cure Surgicals, Vishal Surgicals, Arena Medical Care, Tanish Surgicals, and Boston Scientific. I thank you all for coming to Jodhpur for this Issfn CME. Thank you so much for providing us the opportunity to host this wonderful conference. Thank you so much. We have high tea and some brunch. Yeah, we can have a group photograph. Thank you. Yeah, we can all come onto the stage and have a group photograph. Please, all the delegates, residents, everyone, please come on stage.
आप पीछे यहाँ साइड में आ सकते हैं। क्या करना है? इधर आना है? पीछे वाले दिखाई नहीं दे रहे सर। पीछे वाले दिखाई नहीं दे रहे। The youngsters don't have very tight pants. मेरे से पीछे वो 4-5 जने वो नहीं दिखाई दे रहे।
ये रेडी तो बोल देना, नहीं तो हम लोग को
बिल्कुल बिल्कुल।
और कुछ